ease my mind. In the shadows, can you feel the light? Calling to you from the brighter side. Oh, the rain can't stay. When you feel like you're running in place, feel a shift in the sky, gon' change. Take me there to the good old days. Cause you know it's only gonna get better. Yeah, the seasons know when to change. Better weather don't last forever. Oh, you know things never stay the same. Never stay the same. It's gonna get better. Never stay the same. It's gonna get better. 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 Easy to get caught up in the fight when you've been wrestling with the night. The trouble's waiting there behind my eyes, evaporating with the new sunrise. Oh, the rain, no, the rain can't stay. When you feel like you're running in place, feel a shift in the sky, gon' change. Take me there to the good old days. Cause you know it's only gonna get better. Yeah, the seasons know when to change. Better weather don't last forever. Oh, you know things never stay the same. Never stay the same. It's gonna get better. Never stay the
Not good in some sectors.
No.
So good evening, everyone. We're live. So hello, bonjour, quoi, and thank you all for being here today at the Board of Health meeting. It's our 25th of this term. I'd like to begin the meeting by honoring the Algonquin and Anishinaabe Nation, land and people. Ottawa is located on unceded territory of the Algonquin Anishinaabe and is a gathering place for many Indigenous people. On behalf of the Board of Health and everyone at Ottawa Public Health, I would like to honor the land and peoples of the Algonquin Anishinaabe Nation, whose ancestors have lived on this territory for millennia, and whose culture and presence have nurtured and continue to nurture this land. I'd like to extend that honor to all First Nations, Inuit, and Métis peoples, their elders, their ancestors, and their valuable past and present contributions to this land. We're going to start off the meeting tonight with kind of a special announcement. And I see that Wendy has joined us not only by voice, but by picture. Good evening, Wendy. For those of you who don't know her, I'd like to introduce Wendy Mukel, the Executive Director of Ottawa Inner City Health, who we are recognizing today. Partnerships and local collaborations across sectors have always been an important aspect of public health work, whether it's working directly with the community or working with partner agencies and organizations, from social services, schools, healthcare providers, and researchers to emergency responders and others. OPH values its productive working relationship with its partners and stakeholders in promoting and protecting the health and well-being of Ottawa residents. Partnerships have been especially important in responding to the overdose crisis that has affected so many communities across Canada, and more recently in the COVID-19 pandemic response, which has informed and motivated new ways of working across health and social systems. It is in this context that today we recognize and honor Ms. Wendy Mukel, Executive Director of the Ottawa Inner City Health, for her career-long commitment and achievements in improving the health and wellness of people experiencing homelessness and those living with mental health and substance use health challenges. Wendy has been a leader in Ottawa and beyond in advancing harm reduction and in advocating for the rights and well-being of people who experience challenges with substance use. She has also been a leader and an advocate for the meaningful inclusion of those with lived and living experience in all aspects of service planning, delivery, and evaluation. Wendy has worked to advance numerous initiatives outlined in the Ottawa Community Action Plan, and particularly harm reduction efforts by contributing to increased access to and integration of harm reduction services in our community. She has also been the leader and partner with OPH on the Lowertown Byward Market mental health strategy, working towards improving outcomes for people in need of mental health care and substance use health care and the overall community. During the pandemic, Wendy has been involved with the Human Needs Task Force, leading the Congregate Living Task Group for the Champlain Mental Health and Addiction Network. Ensuring the needs of many continue to be addressed. She has also worked closely with other community service partners throughout the pandemic to support people experiencing homelessness by adapting services to protect the community from COVID-19. As a result, she has had a significant impact in healthcare delivery across the shelter system. She is a servant leader through and through, always ensuring that she has the pulse of what is happening and what is needed through regular check-ins with her team. The people who know her and work with her are continuously amazed by her passion, her commitment, and her work ethic, but also by her ability to navigate the system, partners, and politics while never losing sight of the end goal, people in need of a hand up and a space to use their own voice. Wendy is recognized by her peers, her team, persons living with lived experience, and the Ottawa community as a person who has demonstrated perseverance and commitment to improving the lives of others. Though we were sad to learn that Wendy will be retiring later this year, we've been honored to have her as a partner and a friend for the past many years. We're happy for her and wish her a happy and healthy retirement. Please join me in congratulating Wendy on her upcoming retirement and thanking her for her years of dedication and service to the health and well-being of the people of Ottawa. So I know you're not here with us, Wendy, in person, but you're certainly here with us in spirit. So on behalf of the Board of Health and Ottawa Public Health, it's my honor to virtually present you with this certificate, recognizing your career-long achievements. We'll make sure the certificate is delivered to you in coming days. I don't know if everybody can see this, but that's the certificate, and we'll make sure that you get it, Wendy, and it'll be nicely framed and everything. And thank you so much. And just in going through that, I hope that what you really have is an opportunity just to sit back, put your feet up for a few minutes, and catch your breath, because it certainly sounds like you haven't done a lot of that in the last little while. I don't know if you'd like to say a few words, but we're more than happy to have a listen if you are.
Well, thank you so much. Very humbling and far too long. However, I have been at this for a long time, but I thank you so much. And OPH has been a founder of Inner City Health from 21 years ago, and the strongest partner and advocate right up to and including today. And definitely, I don't think any of us would have gotten through COVID without each other. It really has been, as Vera always says, it's a team effort, and it's never been truer than it is now. I was thinking back actually to when this whole thing started and when we first started talking about about what was possible. And I think that 21 years ago, a lot of the things that we now think are normal and are just how we do things in Ottawa really at that time seemed impossible. And, I think we all dreamed of a time when we would have services for people who use drugs. And we dreamed of a time when people with lived experience would rightfully take their place as leaders in our community. And I don't think at the time we understood what was possible. We do now understand what is possible, and there's so much further to go. And I know that I leave those dreams, those hopes, those aspirations in very good hands with all of the leaders in this community, including the Board of Health. And so my challenge to you really is to think about what's possible, to dream of the impossible, and then to work together to make it happen, because that's really how the positive changes have come to our community. It really has been a whole of community effort. So thank you so much.
Thank you very much. Madam Secretary, if I can get you to do the roll call, please.
Yes, Chair. Member Banham?
Present.
Membre Cloutier?
Présent.
Member El Shantari?
Present.
Member Gower?
Here.
Member Kavanaugh?
Here.
Member Lakin?
Here.
Member Menard? Member Pinel?
Présent.
Member Tilly?
Present.
Vice Chair Di Giovanni?
Present.
And Chair Egley.
Here.
You have quorum, Mr. Chair.
Thank you very much. We have only one regret, Member Menard. So I'll just run through the procedures for the Zoom meeting. The following procedural guidelines are being implemented to promote orderly proceedings of this virtual meeting. Should members need to leave the meeting, they should advise verbally that they're doing so before clicking on the leave meeting from the Zoom platform or ending their call if participating by phone. I will provide each member with the opportunity to ask questions or comment. Members will be called on to speak in the order or reverse order as set out in the board secretary's voting list. The usual 5-minute limit will apply. Should you not wish to speak on a given matter, you may decline verbally when your name is called. If a full recorded vote is not taken at for a given item, I will specifically ask if the item is carried and then call for dissents to ensure that all votes are properly registered. Procedural interjections such as points of order, privilege, or challenge should be kept to a minimum to ensure the meeting proceeds smoothly and to minimize confusion. For points of order where you have not been called upon to speak, please state your name aloud for the record before stating your point of order. Should technical difficulties or other unforeseen matters require a recess during the course of the meeting, unless the board secretary issues new instructions, members are requested to remain on the line. The board secretary will mute all participants in such an instance. I don't believe that there are any declarations of interest. Could we have confirmation of the minutes of the meeting of June the 20th, 2022? Confirmed?
Okay.
Confirmed.
Thank you. We've received 6 communication items. They've been received and they're held on file with the Board of Health Secretary if anybody wishes to see them. I'm going to ask Member Banham, who's helping us out tonight, for the motion to introduce reports, please.
Yep. All right. Be it resolved that the presentation by Dr. Daniel Myran, Cannabis Poisoning in Children Following Non-Medical Cannabis Legalization, the Chair of the Board of Health Verbal Report, the Medical Officer of Health Verbal Report, and the reports titled Health Equity, Diversity, and Inclusion at Ottawa Public Health, Reconcili-Action Plan Update, Annual Report, Results of the Third-Party Review by Dr. Paul Gully of Ottawa Public Health's COVID-19 Response, Recovery Planning Status Update on Ottawa Public Health's 2022 Fall Immunization Plan, Ottawa Public Health Strategic Plan for 2019 to 2022, update from Q2 of 2022, 2022 Operating and Capital Budget Q2, Board of Health for the City of Ottawa Health Unit Status Report, Delegation of Authority, contracts awarded for the period of January 1st to June 30th, 2022, and performance appraisal of Medical Officer of Health in camera, personal matters about an identifiable individual, reporting out date not to be reported out, be received and considered.
Carried. Yes, carried.
Carried.
Okay, thank you. We'll now go through the consent agenda process. For those participating or watching from home who may not be familiar with this process, I will list each item on the agenda, and for any items where board members don't have any questions or concerns, and we don't have public delegations registered to speak, the board may carry or receive those items on consent, which is to say, without any discussion. So number 1 on the agenda is a presentation by Dr. Daniel Myran, Cannabis Poisoning in Children Following Non-Medical Cannabis Legalization. We're going to hold that for a presentation. Second is my verbal report, so we'll hold that. Thirdly is Dr. Etch's verbal report, so we'll hold that. Fourth is the Health Equity, Diversion, and Inclusion of Ottawa Public Health presentation, and we also have public delegation, so we'll hold that as well. Number 5 on the list is our Reconcili-Action Plan Update Annual Report. We don't have any presentation for that, but staff are certainly available to answer questions if anybody has any. If not, can we receive the report?
Received.
Thank you.
Received.
Chair, if we can carry that, please. There are
Oh, sorry.
recommendations.
Carry the
Yeah,
report rather.
thank you.
Carried.
Carried.
Number 6 is the results of the third-party review by Dr. Paul Gully of Ottawa Public Health's COVID-19 response. We do not have a presentation for that, but Dr. Gully is available to answer any questions people might have. I know I have a couple of questions, so for that reason alone, I'm going to hold it. But if anybody else has questions, as I say, Dr. Gully is here and he'll be able to answer those questions for us. Number 8 is an update on Ottawa Public Health's 2022 Fall Immunization Plan. And we have public delegations for that, so we'll hold that
Chair,
one as well.
we missed number
Sorry?
7. We missed
I'm
number
sorry.
7.
Number 7, recovery planning status update. Can we carry that?
Carried.
Carried.
Okay, thank you. Number 9 is Ottawa Public Health Strategic Plan for the 2019-2022 update from Q2 of 2022. Can we receive that?
Received.
Thank you. Number 10 is the 2022, excuse me, operating and capital budget Q2 Board of Health for the City of Ottawa Health Unit Status Report. Received?
Received.
Thank you.
Received.
Number 11 is the delegation of authority contracts awarded for the period of January 1 to June 30th, 2022. Received?
Received.
Thank you. Number 12 is performance appraisal, medical officer of health in camera, personal matters about an identifiable individual, reporting out date not to be reported out. Can we carry that?
Carried.
Okay, thank you. We'll now go back to the first held item then, which is Dr. Myran's presentation. Do we have Dr. Yes, there he is. No stranger to Ottawa Public Health. Welcome back, Dr. Myran.
Thanks for having me here.
We'll just turn it over to you.
Okay, great. So thanks for having me to the board and to chair. And Diane, you're gonna click through as I go. Okay. So it's I'm very happy to be here tonight talking about some changes in cannabis poisoning in very young children that's been occurring across the country since legalization. And if we'll go to the next slide. And so I'm Dr. Myran. I'm a family physician and a public health specialist. I have an addiction medicine practice here in Ottawa, and I spend a lot of time doing research on drug policy. I have no conflicts of interest to disclose, no financial or otherwise. We can head to the next slide. So what we're going to do in the next couple of minutes is look at some of the policies surrounding cannabis legalization in Ontario and across Canada. We're going to talk about 2 studies that I led looking at changes in cannabis poisoning in young children after legalization, and then discuss some of the roles or actions that local public health could consider taking. So as a background, we legalized non-medical or recreational cannabis in October 17th, 2018. And the prior experience from Washington and Colorado State was that they observed that young children, typically under the age of 9, had fairly large increases in cannabis poisoning after they legalized non-medical cannabis. And as part of our package of legalization, Canada put in policies to try and stop these kinds of events from happening. And that included child-resistant packaging, plain packaging, limits on the actual quantity of cannabis that could be in each package, and consumer education campaigns. And one of the other things that we did was we had a phased approach to the introduction of cannabis products. So when we initially legalized cannabis, only the sale of dried cannabis flower, seeds, and oils was allowed. And then beginning in January 2020, provinces were allowed to start selling new types of cannabis products called by the industry Cannabis 2.0. This is vapes, this is edibles, beverages, concentrates, an extended variety of typically higher potency cannabis products. And what's important is that some of the provinces that we're going to talk about tonight, Ontario, Alberta, and British Columbia, all allow a wide variety of these new products to come to market. In Quebec, over concerns that they could appeal to very young children and youth, say that there will be no new products in the form of candies, chocolates, and other sort of sweets or sugary products. So this is the first study that I want to talk about, and this study is specific to Ontario. And what we did is starting in January of 2016 and going until March 2021, we looked at every single emergency room visit in Ontario amongst children aged 0 to 9. And we identified emergency room visits that were caused by cannabis poisoning specifically. And what you see is as you look at this graph, we see that starting in, and can you guys see my cursor? And people nods maybe? No, okay, you can't see, that's okay. So if we start on the left of this graph, we see that these events are very rare in January 2016, and that's before legalization, which happens in October of 2018. And that the events are actually slowly increasing over time, pre-legalization. And if you look in this pre-legalization period, you see on average 2.5 emergency room visits a month in Ontario caused by cannabis. In period 1, which is when we have limited cannabis products come to market, that trend continues, but there's no real jump. And you move up to 7 visits on average a month. And then in period 2, which is when we have our new edibles rollouts, you have, again, candies, gummies, you see that these visits in young children increase to 22.5, so a 9-fold increase. And the visits have actually become substantially more severe as well. So by the end of the study, 40% of these children actually need to be admitted to hospital for further interventions and monitoring, and that was only 23% at the start of the study. So if we look at Ontario, there's been a real increase, a 9-fold increase in the quantity of emergency room visits in the province caused by cannabis poisoning in young kids, and they've gotten more severe. We can go to the next slide. Okay. And so this is a second study that we did. And this one, it's we're going to look, so it's the same age group, kids age 0 to 9. And we're looking at 4 provinces now. So Ontario, Alberta, and British Columbia, and Quebec. And if you remember back earlier, I talked about how Quebec doesn't allow the introduction of these new edible products. And we tracked hospitalizations for cannabis poisoning in these kids over time. And we start in 2015 and go till 2021. And what we see is that all 4 provinces have a very similar pattern before legalization. They have a similar change after legalization. These hospitalizations go up by 2.5 times. But that when these edibles come to market in January 2020, you see a further 2.9 increase in Ontario, Alberta, and British Columbia, and Quebec sees no further increase. So one of the stories that's happening here, and we have to keep in mind, these are actually quite severe events. There's 581 of them in the study, but these are children who are actually being hospitalized for cannabis poisoning, and a substantial portion of them go to the intensive care unit for help with their breathing. So these are quite severe events. And I think that the takeaway here is that we've seen a 6 times increase in these hospitalizations for poisoning over time after legalization, but the increase in the provinces that allowed edibles to come to market has been double that of Quebec, who didn't allow them to come to market. So in response to these studies, there's been some objections from representatives of the cannabis industry. The first main one is that these aren't actually real poisonings, that the kids have kind of, had someone reported that they had a cannabis exposure, but that these kids aren't sick. I'm not, one of our study authors is a ICU pediatric physician who deals with cannabis poisoning. And, it's not my clinical experience. I work with adults, but these kids are very, very ill. These are, you have to consider that they're having an ingestion of a product that's meant to cause an intoxication or high in an adult. And the kids on average are 3.5, and they're quite sick. And some of them without medical intervention do have a real risk of dying. The other objection is that maybe this is just, we legalized cannabis and parents or caregivers are now more willing to disclose that cannabis has been used. And if we go back a slide, that's a really nice explanation for why you might see a small increase immediately post-legalization, but it doesn't explain why these visits start increasing massively when edibles come to market. And it also doesn't explain, you'd have to assume that parents in Quebec, for some reason, don't disclose cannabis use, and parents everywhere else in the country do. And similarly, there's been an idea that these poisonings might be from illicit cannabis products. And again, we know that the illicit market has actually contracted by around 50% during the study period. And it would be strange for there to be a sudden surge of interest amongst parents and caregivers in illicit cannabis, following legalization as the market is shrinking, and only in the provinces with legal edibles and not in Quebec. So we can go ahead to the. I do always, when I talk about these findings, I always contextualize it by the enormous social harms that come from our approach to criminalization of substance use. And this is a figure showing rates of police-reported cannabis crimes in Canada, starting in 2016 and going to 2020. And when people have a criminal record for cannabis possession or use, it can be life-altering. You have problems with employment, problems with education, and we know it's been well documented that this was highly discriminatory. So as we think about legalization of cannabis, there's an immense social harm that has been improved. But the argument that I'll make is that if you actually look at this graph, the rate of these harms was declining pre-legalization. And I'll make the argument that you actually don't need to sell candies containing cannabis covered in sugar in order to get rid of the criminal justice harms that arise from our prior approach to cannabis. So the takeaway is the frequency and severity of cannabis poisoning has increased in Canada. There's pretty strong evidence that legal edibles have been a key contributor. This problem may actually get substantially worse. Health Canada is currently reviewing the major piece of legislation that legalized cannabis, and the industry has been proposing that they remove several of the regulations that I talked about at the start that are in place. So limits on THC, marketing, packaging, all because they say that these create problems of competing with the illicit market and they cut into profits, and they would like to see these go. And the caution that I would raise is that we had a large increase in these poisonings and their severity with these policies in place, and that if they go, you could actually see more poisonings and more severity. And now we're into my obvious lack of reading French. There you go. So I think that as we talk about what can local public health do, I think that there is always a possibility or a role for greater education for parents and caregivers. We have to keep in mind that we've done this. Ottawa Public Health is engaged in some promotion, the federal government and provincial government have done so. And I just think that we should be very pragmatic where, we can put more education at this issue, but I don't think that we should expect to see major results. And that's not to say that it's not worthwhile. But I think that as we look at this as a public health problem, and if we think about actions to take, I think education is only one step. The big opportunity that's happening is right now we are reviewing at the federal level how cannabis is regulated. And I think there's an opportunity if local boards of health are interested in giving submissions to Health Canada with their perspectives. And I think that those submissions would pair very well with, for example, if Ottawa Public Health wanted to partner with CHEO, who has some of the clinical background, and you can certainly generate the local context of the number of these poisonings that are occurring both in emergency room visits and hospitalizations. Right now, that consultation is not accepting public solicitation, but it will be in the near future. And I think that that is an opportunity. Similarly, the provincial government has some ability to regulate the types of products, as we've seen from Quebec. So, they made a choice not to allow edibles to come to market. And Ontario, if it wanted to do that, would be in a position to do that. So again, I think it's certainly an option for local public health to write to the ministry or to the minister outlining some of their concerns. So here's some references. I'm very happy to chat with people, take some questions, and thanks again for the invitation.
Thank you very much, Doctor. I know I have some questions, and I see that we'll start. I see that Member Kavanaugh has her hand up, and then Member Cloutier. So over to you, Member Kavanaugh.
Thank you very much, Chair. And thank you very much for the presentation. I think it should be taken very seriously. I appreciate it. And it's a tough balancing act when we want to see legalization of these products in terms of cannabis overall. But the candy business is problematic. It kind of reminds me of children aspirin way back when they had sweetened children aspirin. And you had to keep that away from kids. That's from the old days. But I appreciate the seriousness of this and the focus. Are we seeing any issues in places like Gatineau that are right next door to Ottawa, or is it done provincial wide? I'm just curious if it's a concern there, because they may have the rules in Quebec, but maybe people are going across and buying products in Ontario and Ottawa.
Yeah, I think that, Ottawa is in a unique circumstance that we're so close to Gatineau. The studies that we've done are at what we call the population level. So we look at every healthcare visit for every individual in a province. Because these are rare enough, you actually, you start getting into identifiable information. If I figured out, in the month of February, someone was in Gatineau and had a visit, it's probably possible for an organization like CHEO to take a look at the postal codes of where people are coming from and see, as the catchment area for severe poisoning, they would certainly see people from Quebec who've come over to them. I think that the bigger piece is that whether or not there's some movement of products between Ontario and Quebec, it does seem that the decision to not allow these edibles to come to market has been highly protective in this young population.
Yeah, no, I appreciate that very much. Is there permanent damage to children? I guess it's really hard to know that without a longitudinal study, but is there any possibility of that?
Yeah, it's an open question. There haven't been any studies looking at long-term impacts. It's a very tricky study to do. I think that if you think about it this way, these are young kids. They're on average 3.5. A lot of them, when you're coming into hospital, it's a very intensive experience. A lot of these kids get CT scans of their head with a large amount of radiation exposure. A lot of them need lumbar punctures where someone needs to make sure that they don't have a serious infection in their blood or spine. And all of this, aside from the potential toxicological effects of the cannabis, the interventions themselves that are needed to support and manage these kids are quite traumatic. These are not things that involve sedation for children, medical exposure. So I think that this is a very stressful time for young kids, which may have mental health impacts in the long term. It's very well recognized that adults who go to the intensive care are at high risk of mental health comorbidities long term. Less is known about kids, but you would assume it would be a similar relationship. And then I think the questions of, brain impacts of what cannabis can do long term is totally unknown, but, you could have reason to be concerned.
Okay, thank you very much.
Thank you. Next on the list, I have Member Cloutier.
Thank you. Thank you, Chair, and thank you, Dr. Myran. I appreciated the presentation. You touched on a little bit of the data that I wanted to get to. You're saying that the average child is 3.5 years old who is visiting.
Yeah, these are young kids who presumably, and I have young kids at home. They're very good at getting into places that you think they shouldn't. And it's clear that, the deterrents that are in place, and there is child-resistant packaging on this, but that is either insufficient to keep the young kids out of the product, or these products are being removed from their original packaging and stored in a way that's accessible.
Right. And so that answers my question. And so there were, you said there was 500 visits to emergencies in most provinces, excluding Quebec, perhaps absolutely excluding Quebec, from October 2019, which is a year after cannabis was legalized and the edibles came to market, until earlier this year. Is that correct?
So there was 580 hospitalizations across the
580?
entire, for all 4 provinces for the whole study.
Got it.
There's, I don't have the exact numbers, but there's 350 during the edibles period.
Okay.
One of the things, you can look at these numbers and you can say they're not that high, but they're the most severe of the events. So if you have when these kids are coming into hospital, there's a larger number of emergency rooms under that. There's an even larger number of calls to poison control. And then there's an even larger number, in this injury pyramid of exposures that happen where someone's like, oh, maybe they got exposed, maybe they didn't, let's monitor them and see how they're doing. So this probably represents a much larger number of these poisoning events.
I completely agree. I am not minimizing in any way, shape, or form the
We might have lost you.
I think we have lost member Cloutier. So maybe we'll go to the vice chair, and if he unfreezes, we can follow up with him to see if he has any other questions. So I'll turn over to the vice chair.
Sure, thank you, Chair, and congratulations on this study. I really appreciate the Canadian context and contextualizing the greater social good with, some of the risks, and it's about mitigating those risks. So I really appreciate that. You may have answered this question, so I apologize. I just wanted to clarify. Did your study differentiate between parents, caregivers that had taken the edible out of the protective packaging and then stored it, versus those that, it was the Riley wise 3.5-year-old that was able to get it out of the packaging? And not that I think that I just don't want to misconstrue my question. It's we always do hear it's all about education, and it's we all know it's not all about education, and so I just wondered if your study had looked at that at all.
Yeah, so it's a great question, and this is it's the fundamental limitation of the data. So this is health admin data that we have, right? It's routinely, the advantage is it's routinely collected. You get it for everyone in Canada. It's diagnoses, so this is not just someone saying, hey, I may or may not have, taken some cannabis. This is, you were in the hospital and you were poisoned with cannabis and the treating team treated you for that. The disadvantage of that is that you have no granular information on the circumstances that led to the poisoning. And you need different studies to get to those questions, and they can help identify, what were the preceding incidents? What can we potentially think about? Our study design is really good at tracking the overall change. And in this case, because of this clear difference in policies between the rest of Canada and Quebec, identify edibles as a major culprit in what we're seeing.
That's great, thanks, and really robust in your analysis. I'm certain there's people in the Ottawa area who'd be happy to partner on the next stage.
Okay, well, thank you.
Member Lakin's next.
Thanks, Chair. Thanks, Dr. Myran. Listen, the frequency of the events may be low, but the data is certainly compelling. And the consequences of the events are potentially dire. I wonder if the data or your other work might shed any light on the mechanism of exposure. Do we have any data on what the mechanism of exposure to the toxic substances might be? And secondly, does that give us any guidance in the recommendations we might want to make to reviewing bodies or governing bodies about safety mechanisms that could be added?
Yeah, I think that our data has some limited implications there. I mean, one piece to consider is that kids can get, so we currently have a maximum of 10 milligrams of THC, the psychoactive ingredient in cannabis, per edible package or per cannabis package. And that even that amount can actually make a kid quite ill if they ingest it all. The kind of, again, the timing, this experiment that was created suggests that edible products, specifically legal edible products, are playing a big role. And we know from prior studies, which may or may not generalize well to our current period, but that when you review these things, most of these poisonings are from edibles, from edible products. And it's actually related to the toxicology of this. So if someone, not that a 3.5-year-old is going to eat a large amount of dried cannabis leaf, but they actually won't get sick from eating that because it needs to be combusted to become psychoactive. The edibles have been treated in such a way that it's already active. And that's, again, it creates the dangers that this is a product that can intoxicate and poison. It's highly appealing, and it requires no further processing before it can be active and make kids quite sick. I don't know if that answered your question, though. And I think you're on mute.
Yeah.
I got it. Thank you. Yeah, if I might be allowed just to follow up, I appreciate that you didn't, as part of the investigation, examine methods of exposure. But given that what would appear to be a done deal in that these products are coming to market or at market, from your own experience, do you have any guidance or observations about further safeguards for these products that we can be aware of?
So I think that the first piece is that we're at a very dangerous moment for cannabis regulation, because as this review is ongoing by Health Canada, there is the possibility that things can change quite substantially. And I would be very, very concerned, for example, if the 10 milligram limit was removed and you started having 100 milligram products, which is what the industry is asking for. And I think you go from a kid who is showing up in Emerge and being monitored for several hours and maybe needs intravenous fluid, and someone comes by to check on their breathing, to a kid who ingests one of these and is headed very rapidly to the ICU for a prolonged stay on a ventilator. And that is and those happen sometimes in our study. If you put 100 milligram THC products on the market and they stay in the form that they're in, you could have a lot more of those. So I think I think the idea that some of these regulations, which were based off decades of experience from alcohol and tobacco control, might be rolled back right now would be concerning. I think as you think about what can we do as the cat out of the bag, we have these products, they're on the market, it's very hard to pull them back in. I think it's an honest conversation about, do you need to have products that are as appealing as they are in sight and taste to young kids? Can adult consumers get the choice that they're looking for through other forms of cannabis that are not red, covered in sugar, and in the shape of a gumdrop? And that's a societal conversation, and a conversation with regulators and industry if they're part of the conversation, and public health has a key role to play, and it speaks to this this tension of the goal of the Cannabis Act is both to reduce youth cannabis related harms in Canada and also to replace an illicit market. And I always talk about, there's this tension because the things that will get rid of the illicit market and do it fast probably also promote some degree of harmful cannabis use in young children and youth.
Member Banham, the hands up again.
I know, I went back and forth and thank you.
The floor is yours.
Thank you, Dr. Myran. That's a great presentation, and you answered most of my questions by answering others. But I'm wondering, prior to us meaning Canada, going through legalization, we used to look to Europe or to like the Netherlands, Amsterdam, on their data and research. And I'm wondering if they have faced the same challenges with products in children, or if any of that had been part of the literature review, et cetera, as you did these studies.
Yeah, so there is this scenario that Canada is pretty unique because we're the second country in the world to do this at a federal level. And when you look at legalization, there's this whole spectrum of what you can do. So, Amsterdam is more on the level of decriminalization with a gray market where people tolerate the presence of coffee shops that sell cannabis, but has less of an established industry who is creating and selling new types of products. Colorado and Washington are the two most comparables. Still, cannabis is illicit at the national level in the US, but these have states who allow a real commercial industry to come to market. They have retail shops, they have new products, they had less regulation on their edibles than us, and they saw increases in poisoning similar to us. One of the advantages is that Canada has much better health admin data than Washington State and Colorado. So, they have be the equivalent of CHIO does a study talking about how these poisonings change. And it's great. You can get all sorts of granular data, but you don't know what's happening in the rest of, the province. You just see what's happening in your city. So that's kind of been one of the adds of this, is that we've done this nationally for Canada to understand how things changed. But this is not I would say, I study, what has happened to adults and youth and young adults. The clearest evidence of a major harm that's happened has been the poisonings in these young kids. It's consistent with the literature. It's fairly robust. And I think there's little debate or little alternative explanation to what's going on. You look at the rises in cannabis use disorders in youth and young adults after legalization, and you can start telling me maybe this is a COVID effect. And I'll be worried about the contamination of the pandemic. Young people being at home without schedules and under stress, and maybe that did lead to increases in cannabis use. And that's not really a great explanation for these cannabis poisoning changes.
Thank you, Doctor. I don't see any other hands. If I have a couple of quick questions. You talked about the increase in the number of hospital visits when the edibles were introduced. And maybe your study didn't take this into account, but was there a shift in buyer's choice? So people were buying more traditional forms of cannabis, let's say, when the edibles became available. Are edibles, I guess, outselling? Or if you follow me, are more people having edibles in their home than they're having the more standard fare?
Yeah. Are people substituting dried cannabis for edibles? The story of the legal industry in Canada is that it had an exceptionally slow start. And there was there was this notion of the sky will fall. We've legalized cannabis. Everything's gonna, the streets will be filled with this vapor of cannabis and everyone will be addicted. And we had such a slow market at the beginning. There was no retail stores in Ontario. There was major product shortages, but the market is very steadily growing. And people who look at the supply and economic side say that it'll probably take another 2-3 years to reach full maturity. So at this stage in time, you just have every type of product is growing. Edibles are one of the fastest growing product sectors, but month over month, year over year, all forms of legal cannabis are growing. And the sale of them is actually growing faster than the sale of illicit cannabis decreasing. So you do have, this is not a one-to-one market replacement where the illicit market is shrinking and the legal market's replacing it. There's still an illegal market, and the legal market is growing faster than the illicit market is shrinking. And what that means, in alcohol, and I also do alcohol research, you have the notion of the volume of alcohol that a population drinks per person is very, very predictive of the types of harms that you see from alcohol in society. And there's probably going to be a similar relationship with cannabis, that the more cannabis that you sell per person, the more that there's cannabis use disorders and child poisonings and other cannabis-related problems.
Oh, thank you for that. I couldn't help as you were presenting and where they're doing more consultation and talking about more education. I couldn't help but think of the parallel with what we went through with the higher levels of government around making gambling more accessible. We'll just tell people it's bad. We'll make it more accessible. We'll just tell people it's bad, and that will take care of it. And we know that has not worked all that well. And, you know, this is not dissimilar. Some people can use cannabis and they'll be perfectly fine. Kids are not, young kids especially, don't fall into that category. And as she pointed out, could be in grave danger, especially if this review increases the size of dosage that people can buy legally at the retail stores. So I guess my question is for Dr. Etches. A suggestion was made, Dr. Etches, by Dr. Myran, that we may be able to work, OPH might be able to work with CHIO to put together a joint submission to the review process that's ongoing. Is that something that you're comfortable with, something we need to bring a motion, direct you to do? If you can help us help you, then we're happy to do that tonight.
So I would certainly, speaking on behalf of the team that's been engaged in looking at this, and thank you so much, Dr. Myran, for speaking so clearly about the options and the harms and the policy approaches that are important. So our team would like to take this track of making sure it's very clear what we would like to see as more protective measures in the federal consultations that are coming up, and we're happy to look at the provincial opportunities as well. I think I don't want to commit CHIO, so I would take that part off and just say we'll connect with many partners, and there's many Kids Come First partners will probably be interested in terms of in doing the work to put forward our advice and looking at bringing a clinical picture, I think is what your point was, Dr. Myran, to benefit from that view. I mean, we do have data about the local emergency visits in Ottawa. They have increased since edibles came onto the market. It was also the same kind of large jump that wasn't present before locally. So I think we can use that data.
So Dr. Etches, do you need anything from the board? Any motion, any direction, or are you comfortable with just what we've talked about here tonight to be able to go off and do that work?
I think it's helpful to have the Board of Health support for policy recommendations. I think what we would normally do is we prepare the submission and we would bring it to the board for support.
Okay. And Dr. Myran, before you go, do we have any significant timing challenges on that as to when that work would need to be done and submitted?
So yeah, it's a funny question. The review legally began 3 years after legalization, which was not this upcoming October, but the last one, and they have 18 months to finish it by law. My understanding is they are very, very behind. I think that they will, so that they have until, mid 2023 to wrap this whole thing up. I think they're moving as fast as they can, and I would not be surprised to see public consultation starting in early 2023 as they look to meet their like legal deadline.
And we can work ahead and get the policy recommendations done before consultations open, so they can be ready to put in as well. So we'll take this away as a time-sensitive option.
Perfect. Thank you, both doctors. I see no other questions. So thank you very much, Doctor. And members of the board, can we receive this presentation for information?
Received.
Okay. Thank you very much. Thank you again, Doctor. Really appreciated it.
Thanks for the invitation. Have a good evening, everyone.
The next item is my verbal report. For the past 20 years, OPH has been actively involved in the Ottawa Pride Festival. OPH has been and continues to work alongside the 2SL LGBTQIA+ communities to eliminate barriers and address systemic discrimination to ensure access to welcoming, safe, supportive, diverse, and inclusive environments, free of stigma and discrimination. Again, this year, OPH partnered with the Community and Social Services Group to mark the launch of Pride Week in Ottawa by raising the Pride flag in front of the Mary Pitt Centre at 100 Constellation. The event was held the morning of Monday, August 22nd, and was live streamed on YouTube, allowing the community and employees to participate virtually. As chair of the Ottawa Board of Health, I was proud to be there to take part in that ceremony. I was also proud on Sunday, August 27th, participate in the Pride Parade alongside OPH colleagues, friends, and family members. The Pride Parade is always fun, colorful, and it was all the more so this year by the fact we were not riding on top of a float, but rather we were all walking together, which made it easier to interact with fellow parade participants and spectators. And I especially, for those who were at the parade, will understand this, especially want to thank Phil, I don't know if he's listening in, for being our parade marshal and keeping us in line as we went ahead as a group. So I want to thank everyone who attended and participated in this event, and special thanks to the OPH staff who helped organize this activity to promote inclusion and well-being with the Rainbow community in Ottawa. On August the 31st, Dr. Etches and Ottawa Public Health staff came together with community partners, persons with lived experience, and family and friends from across Ottawa at the Canadian Human Rights Monument to commemorate International Overdose Awareness Day. International Overdose Awareness Day is a day to raise awareness, to challenge stigma, and to remember people who have lost their lives due to overdose. Dr. Etches spoke at the event alongside speakers from the Sandy Hill Community Health Centre, the National Overdose Response Services, a service OPH is promoting to better keep people safe if they're using substances alone, Ottawa Paramedic Services, Ottawa Inner City Health, and many persons with lived experience. The COVID-19 pandemic has exacerbated the overdose crisis. We have seen an unprecedented number of overdose deaths, 112% increase in opioid-related deaths in Ottawa from 2019 to 2021, 112%. Systemic health inequalities and toxic drug supply have contributed to too many lives being lost unnecessarily. Dr. Etches stressed we must build systems accountable to implement evidence-based approaches to prevent more loss by better meeting people's health and social service needs. We know that stigma continues to be a significant barrier to accessing essential healthcare services. It is for this reason that Ottawa Public Health and our partners continue to collaborate with leaders in healthcare and social services to promote person-centered approaches, address stigma, and drive system-level evidence-informed change. Working together to adopt a public health approach to substance use, we can begin to address the systemic inequities and barriers facing people in our communities most affected, including work on determinants of health like childhood development and housing. On a similar note, on September the 16th, 2022, just this past Friday, Ottawa Public Health participated in the first ever Working on Wellness, or WOW Festival, formerly known as Recovery Day Ottawa, organized by the Community Addictions Peer Support Association and supported by community partners. The WOW Festival brings substance use, health, mental health, and physical health communities together under one tent to support wellness for all people. And I believe on Friday there were over 200 different organizations and set up to provide information about the good work that they do in our community. Ottawa Public Health has been working very closely with CAPSA and other community partners for several years, including building understanding of the spectrum of substance use health and promoting the use of person-first language, as well as on content for the Have That Talk About Substance Use Health webpage, which is used by organizations to promote the health of employees. Although we have made great strides, OPH is seeking new avenues to address structural barriers while increasing education, training, and awareness of stigma and person-first language. Changing structural stigma requires acting and engaging differently than in the past. For this reason, Ottawa Public Health is grateful for the opportunity to continue working with CAPSA through a new joint work plan. This joint work plan will be executed by one of our Ottawa Public Health nurses who will be joining the team at CAPSA for an innovative secondment over the next year. This will have an immediate impact on the work itself and its uptake in the community. It will also serve as a living education for both organizations on how to create the needed change within the system. Ottawa Public Health would like to thank the organizers of the WOW Festival. Together, we recognize and applaud every person who is working towards wellness, as well as their family and friends, service providers, allies, and community partners who have been and continue to support them on their journey. September the 30th, is the National Day for Truth and Reconciliation, first recognized in 2021, so just last year. This day honors the survivors of residential schools and the children who never returned home. It's also an opportunity to bring awareness to the painful legacy and impacts of the residential school system. To mark the day, buildings across Canada will be illuminated in orange from 7 on September the 30th until sunrise on October the 1st, including the Peace Tower, Parliament Hill, and other federal buildings. September 30th is also Orange Shirt Day, an Indigenous-led grassroots commemorative day intended to raise awareness of the intergenerational impacts residential schools have had on individuals and families to promote the concept of every child matters. The orange shirt represents the stripping away of culture, freedom, and self-esteem experienced by Indigenous children over generations. I encourage everyone to wear orange on September the 30th and to use that day as an opportunity to learn, reflect, and advance reconciliation efforts. On October the 3rd, the Ottawa Black Mental Health Coalition will be receiving the United Way Community Builder of the Year Award at City Hall. The Community Builder Award is presented to community leaders and volunteers throughout the year. Once annually, United Way honors individuals, organizations, and/or initiatives that reflect significant contributions to the social services sector and the community more broadly. I'm happy to share that OPH's very own Hodan Aden has been an instrumental leader in the creation, development, and sustainability of the OBMHC. She is one of the founding members of the OBMHC and now sits on its executive committee. Hodan has been a leader in the African, Caribbean, and Black community for many years and was the lead on the landmark research study, Mental Health of Ottawa's Black Community, which contributed to the creation of the OBMHC and to OPH's mental health strategy and initiatives. Further, Nuruddin Mohammed, another member of the OPH team who currently co-leads the mental health, the health unit's mental health and substance use ACB strategy, has also been an incredible leader in the ACB community for many years. Nuruddin represents OPH at the OBMHC main table of partners, and his approach and dedication to this file has opened many doors for the organization and for our communities, leading to meaningful impacts. On October the 6th, the Mental Health and Wellbeing Research and Training Hub, MeWorth, in partnership with the Department of Psychology at Carleton University, will be co-hosting Psychology Mental Health Day in person at the Richcraft Atrium of Carleton University. MeWorth has established the Courage to Speak Award to recognize the bravery and inspiration of speakers to share their journey. This year, as part of the Psychology Mental Health Day event, MeWorth will be presenting the Courage to Speak Award to OPH's very own Benjamin Lakin. Ben will be speaking at the event, and the keynote speaker will be Dr. Natalie Durant-Bush from the University of Ottawa, who will be discussing the mental health of athletes. All are welcome. More details and registration are available on the Carleton Mental Health and Wellbeing Research and Training Hub. The website address is www.carleton.ca/mental health. Please join me in congratulating Hodan, Nuruddin, and Ben on these well-deserved recognitions. As noted in the Q2 budget status report listed as item 8.10 on today's agenda, during this summer's conference of the Association of Municipalities of Ontario, the Minister of Health confirmed that the province would continue to reimburse local public health units for COVID-19 extraordinary costs. She also announced that the province would continue the mitigation funding through 2023. Members will recall that this funding offsets the decrease in provincial funding that was expected with the implementation of a reduction in provincial cost shared contributions from 75% to 70%. I want to take this opportunity to thank the province and the Minister of Health for this commitment and for recognizing the importance of providing sustainable, predictable funding for local public health units and their crucial work. That concludes my verbal report, and I'd be happy to take any questions. Seeing no questions, can we receive the report? Thank you. I'm now going to call upon Dr. Etches to provide her verbal report. Over to you, Dr. Etches.
Thank you, Chair. Kwei, Unasakut, Tanshe, Annie, and bonjour. I wanted to start by introducing you to Dr. Laura Porns, and I think she is able to put her camera on. to say hello. So you approved a report that has led to her officially joining Ottawa Public Health as the Associate Medical Officer of Health, pending a minister appointment at the end of August. So Dr. Borns was a public health and preventive medicine resident with Ottawa Public Health some years ago, and we're fortunate to have her back with our team. She brings experience having worked with another health unit as well as Public Health Ontario. So if you want to wave, Laura, you're welcome to turn on your camera and say hi.
Apologies, I'm just having camera issues
No
in Zoom,
no
but just wanted to say thank you everyone for the warm welcome. I'm really looking forward to working with Ottawa Public Health, the City of Ottawa, and our board. Thank you.
And of course, we also formally could welcome Pauline Tam as the Director of Stakeholder Relations and Community Engagement. So she's someone you have met since she joined in July, and Joanne Henderson-White is the Program Manager of Health Equity, Diversity, Inclusion. Joanne has additionally taken on the role of the Acting Manager, Performance and Corporate Services for a year to best advance supportive organizational policies and practices that will help with equity, diversity, and inclusion, and you'll hear more about that later tonight. So I do want to take a moment as well to highlight the Reconciliation Action Plan update report. Thank you for carrying it. That will guide our ongoing work, and to thank the community members who provided significant information and shared with us their priorities and concerns that are outlined there and that we'll continue to work on with them. Want to thank Paul Gully, who is here waiting to answer your questions as well, for his work in reviewing the pandemic response. I know it's one piece of the picture of all the work that's going on in many levels around lessons learned from the pandemic. Just seeing the Lancet article released last week with an international view. So there are global lessons for health systems, public health, and beyond. And really, you can tell that understanding the full impact of the pandemic and guidance for future responses will grow over time. Even Dr. Myran mentioning, what we need to sort out with regards to, youth substance use. So the review that Dr. Gully completed, it was to help inform our immediate operations at the local level, to account for what we did and to identify areas to adjust into the future. So I will start off by talking about COVID some more. We have an ongoing role to provide Ottawa residents with the information they need to protect themselves and their loved ones as we head into fall. One of the ways we're doing that is through the weekly snapshot, which continues, and reporting on vaccination uptake. We share this on social media and with key stakeholders. And our monitoring indicators there are showing that the declines we were seeing in the amount of COVID in the community have really leveled off, and that the COVID level is high in our community still. So we have a new tool as well, thanks to scientists working on 613 COVID, that website, 613covid.ca. It's about the percent of tests at some hospital staff that are positive. And that curve is starting to show there could be that they're seeing a rise in the percent positive again. The predictive aspect of that looks like it's going up. And so with the return of school and cooler weather and all the activities associated, it is important for people to continue using layers of protection against COVID-19. These measures, to be really clear, include staying home when sick, wearing a mask indoors in crowded spaces, continuing to practice good hand hygiene. These are things that will protect against other respiratory illnesses like colds and influenza and RSV. And we are expecting in the months ahead that we will see many of these respiratory viruses circulating at the same time in our community. It will put pressure on people and systems in terms of serious illness, disruption of school and work and leisure activities. Dans les mois à venir, on s'attend à ce que plusieurs maladies respiratoires circulent en même temps dans notre communauté, ce qui posera à nouveau des problèmes en termes de maladies graves et de perturbation des activités scolaires, professionnelles et de loisirs. So that's why we are pleased to announce, not pleased that the province announced on September 12th that there is a new bivalent booster vaccine for COVID available to Ontarians 18 and over. It is another layer of protection we can use against the Omicron variants that are circulating in Ontario. We welcome this announcement, and we're working to make sure that that bivalent booster vaccine is available to older adults with a priority in long-term care homes, retirement homes, and congregate settings. These are settings where people may receive the booster dose directly through the homes they reside in, and we're also prioritizing First Nations, Inuit, and Métis individuals and healthcare workers, working directly with community partners and hospitals to make sure that the boosters are available and for the targeted clinics that these organizations run. And in order to optimize our immune response and the duration of protection we have from vaccination, an interval of at least 6 months or 168 days, if you want to count them out, is recommended between your last dose of COVID-19 vaccine and your fall booster dose. So individuals may choose to receive the bivalent booster as early as 3 months or 84 days after their last dose with informed consent. And that bivalent booster will be offered to anyone who has a booster appointment already booked. So people who meet the eligibility criteria can book their bivalent booster dose through the provincial portal or by calling the provincial vaccine contact center. And you do need to make that a phone call if you're looking to receive the bivalent booster dose at a shortened interval. And as vaccine protection from immunity also from previous infections decreases over time, I am strongly encouraging all residents of Ottawa to get all the booster doses they're eligible for ahead of what could be the active flu and respiratory season in our community. Being up to date on COVID-19 vaccine, it continues to be our strongest protection against COVID-19. It helps protect people of all ages from symptomatic illness and reduces transmission to others. The booster doses build on and restore the protection of the first 2 doses to lower the risk of severe illness and death from COVID-19 over time. And it also appears that the risk of longer-term COVID-19 symptoms appear to be reduced when people are vaccinated. So I want to thank people for continuing to come out, continuing to work together to mitigate the impacts of COVID in our community. I also want to encourage people, as you know, this is coming up too, and before our next board meeting, to get the influenza vaccine when it becomes available. Preventing as many respiratory illnesses as possible will help us as individuals, it'll help our whole population, and it'll help our health system's capacity. The influenza immunization program's going to start in a way that is phased as well. So first to residents and staff in hospitals and long-term care homes at the end of September into October. Then access will start to grow for people at higher risk of severe illness, in October. And the general population in November can expect to get their flu vaccine in November. It'll be same as usual through pharmacies, primary care offices mostly. As it was last year, Ottawa Public Health's direct delivery of influenza vaccine will focus on populations with barriers and the youngest members of our community who might not be served by other channels. So speaking of respiratory illness, I mean, it's something that we know people are reporting as they go back to school and education workers return. This is certainly an environment where we know that it's important to stay home if you're sick to help decrease any of the respiratory viruses that may be circulating. We are glad to see the schools are open for the well-being and development of children and youth. And we're keeping an eye on the level of COVID in our community and what else is circulating to be able to prepare different guidance to work with the province if things are worsening from COVID-19 and other viruses. We'll continue to keep an eye on what the situation is, letting people know, and certainly looking at the provincial picture. To prepare for the 2022 to 23 back to school season, the school health teams really been working to expand the kinds of support that schools can receive from Ottawa Public Health. We've, of course, worked with school board stakeholders in planning to look at how to maximize health and safety measures and messaging related to COVID. We've written to all parents outlining how they can use the different layers of protection. and key messages on respiratory etiquette. The teams also worked with the Ottawa Public Health mental health team and the school board's mental health leads. So together to look at the needs of the community, the services available, and how our Ottawa Public Health team can ensure that a focus on mental health remains a top priority as students return to school. We're also using a health equity framework, and we're looking in partnership with internal and external stakeholders around the school communities to really think about how we can address the impact of the pandemic in the school setting, thinking about how we can promote well-being and reach populations who may have had more severe impact from the pandemic, who could benefit from the catch-up on immunization and dental screening. These are priorities, and then programming and services and resources and other health topics will grow as the capacity allows. À mesure que l'année scolaire avance, l'équipe de santé scolaire va examiner et évaluer la manière dont elle améliore, favorise et protège la santé et le bien-être des élèves. So I'll turn to monkeypox and other virus, where we have currently seen 40 people confirmed positive in Ottawa, and we've administered over 4,000 doses of the Immunization vaccine. And an initial observed peak of cases appears to have passed in Ottawa and Ontario. So it's something we're watching closely to see if that continues to hold. But it's an effort that continues. So we're still working with gay and bisexual men who have sex with men, to make sure that they are able to have the information they need. We've been hosting pop-up clinics at healthcare partner sites, bars, sports leagues, bathhouses, major queer events such as the Bingham Cup International Inclusive Rugby Tournament, and Capital Pride, as well as working with post-secondary institutions so that they can also provide the vaccine. We've engaged Indigenous partners and shelter partners also to make sure that everyone can have access. We've adapted the response with community input to include more evening and weekend appointments, tried outdoor clinics. We've really diversified the pop-up clinic options to reach as many eligible community members as possible. And we've built in monkeypox vaccination into our COVID-19 clinics, as well as our sexual health clinic. So we'll continue to promote the protection of the vaccine and work with various community organizations. We've been working in digital spaces as well, including digital and social apps such as Grindr and Squirt and Scruff, as well as traditional social media channels like Facebook and Instagram. We've been working to see partners supported to host Instagram live events. For example, with a queer vaccine PhD, Dr. Swanda, he answered a lot about common myths and misinformations related to the vaccine. And we've collaborated with drag queens on promotion activities, continuing to reach smaller communities who might identify with the bear, kink, and leather communities. So you can see we're trying to close any gaps in our reach, and we'll be reviewing our response. So I wanted to take a moment to thank the partners who've really helped further this work, including Max Ottawa, the Gay Men's Sexual Health Alliance, Centertown Community Health Center, Wabano, the AIDS Committee of Ottawa, the PrEP Clinic, Club Ottawa Bathhouse, Tees Bar, Gay Ottawa Volleyball, the Rainbow Rockers Curling League, the Organizing Committee of the Bingham Cup, and our partners at Capital Pride, as well as the University of Ottawa, Carleton University, Algonquin College, and La Cité, and our team at Ottawa Public Health. They're so committed to protecting our community, and it's really good to see that work's making a difference, especially as we're trying to continue to respond and prepare for COVID in the fall and continue to get back to more of our other work. I just have a couple more subjects to cover. I think it's very relevant. You can hear the importance of thinking about policies and the way we approach decreasing harms from substance use. And so an important substance to consider, considering the large burden of illness that it causes, is alcohol. And the Canadian Centre on Substance Use and Addictions, that's the CCSA, received funding from Health Canada to really take a look at the evidence to update Canada's low-risk alcohol drinking guidelines. And they've released their final report for consultation just at the end of August. And they're expecting then to go forward and release new guidelines this fall. The guidelines looked at a lot of different sources of information, different types of evidence. There were consultations with Indigenous people who served on the Low Risk Drinking Guidelines Executive Committee and scientific expert panels. The report is designed to provide Canadians with an accurate and current evidence-based approach on alcohol and support people in making informed decisions about its use. It's really intended to inform future alcohol policy and prevention approaches. And an underlying idea that's really coming through is that the people in Canada have a right to know. So there are significant changes in the Canadian low-risk alcohol guidelines, alcohol drinking guidelines. The most significant change is in the recommended level of consumption. So the 2011, that's how old the guidelines were. They recommended no more than 10 drinks per week for women, no more than 15 drinks per week for men. That might sound familiar, but in the recommended 2022 low-risk drinking guidelines, there's no differentiation for men and women, and it's a continuum of risk that is presented, risk for alcohol-related harms. So it's negligible to low for individuals who consume 2 standard drinks or less per week. And it's moderate for those who consume between 3 and 6 standard drinks per week. And increasingly high for those who consume more than 6 standard drinks per week. So this work of the CCSA is leading to recommendations for Health Canada to require, through regulation, mandatory labeling of all alcoholic beverages, to list the number of standard drinks in a container, and the guidance on alcohol and health, health warnings, and nutrition information. So this recommendation aligns with Ottawa Public Health's previous Board of Health reports. But most recently in 2021, the board supported a submission where we did make a recommendation to apply the policies that exist for tobacco and cannabis marketing to alcohol regulations. So we are pleased to see these kinds of recommendations coming out of this work as well. Our team has been actively involved in the consultations on the guidelines, and we're continuing to connect with the CCSA staff. So we will be using this information to inform our programming and our policies and community work. So back to infectious disease. The COVID-19 pandemic has caused unprecedented disruption for both routine vaccines given to children in primary care practices and the school-based vaccines that we usually deliver as public health units in school. This is because of decreased access to in-person visits to healthcare providers and because of school closures and online learning that had happened at times since March 2020. So this subject of childhood immunization includes those 2 types. And when you think about all routine childhood vaccines, for all the provincial vaccine programs, in Ottawa, they pass through our vaccine distribution center on their way to providers in the community. And what we're seeing is that some vaccine delivery volumes are still lower than they were pre-pandemic. So this is an early signal to us that there is a growing backlog of children who were under 5 during the pandemic who are not fully protected against important diseases like measles and polio. Tous les vaccins infantiles de routine des programmes provinciaux de vaccination à Ottawa passent par le centre de distribution des vaccins de santé publique Ottawa avant d'être acheminés aux fournisseurs de la communauté, et certains volumes de livraison de vaccins continuent d'être inférieurs à ceux d'avant la pandémie. Et il s'agit d'une signe précoce qu'il existe un retard important dans la vaccination des enfants qui avaient moins de 5 ans pendant la pandémie et qui ne sont pas entièrement protégés contre des maladies importantes comme la rougeole et la polio. So these diseases have the potential to cause outbreaks that could in themselves cause disruption and emergencies in school, work, and recreational settings in the years to come. So this is something that we have avoided due to high routine vaccine coverage in Ottawa, and we want to maintain. Our surveillance and monitoring of vaccine coverage in children is highly dependent on school, as the parents report vaccines to public health for compliance with the Immunization of School Pupils Act. So now that children are back in school, we're restarting, the dedicated efforts by Ottawa Public Health to reach people who've missed the vaccines that we normally deliver in schools against meningitis and hepatitis B and human papillomavirus, which is the cause of cervical cancer. The province has made changes to expand eligibility for these vaccines to include high school students who missed the vaccines normally given in grade 7, and we have started catch-up clinics to reach these adolescents this year. But the challenge of the routine vaccination and catching up with the younger children served in childhood, earlier childhood, it really needs a longer term, larger effort with partners, across the health system, from primary care leaders, Ontario Health teams, and working with the Ministry of Health to make sure that we do sustain and get back to the higher levels that can prevent disease and severe disease that could have lifelong impacts. So more vaccination to come. So I'll finish with the budget update and just a comment on one last report. So as mentioned by Chair Eglai, in the address by the Minister of Health to delegates at the Ontario Association of Municipalities of Ontario conference in August, she did recognize the COVID response is ongoing and it requires ongoing investment in public health units. She confirmed that the ministry is continuing increased investment to support our response, and also her commitment to continuing the mitigation funding through 2023. You'll remember that this funding offsets the decrease in provincial funding that would otherwise was anticipated with the implementation of a 70% provincial contribution to cost-shared programs compared to a 75% contribution. So this is welcome news. It's $3.1 million that will be contributed from the province for Ottawa Public Health. And during our quarterly reporting on our finances to the Ministry of Health, we're continuing to show that the City of Ottawa's contribution is already greater than 30% to the cost-shared programs. So with respect to COVID-19 expenditures, we have been working to reduce COVID-19 related work, carefully looking at what we anticipate we'll need in an ongoing way. And we do see that the resources needed to continue to vaccinate, to analyze the situation, inform the public, respond and prevent and respond to outbreaks, is there. So we are projecting that there will be about $38 million spent for the general COVID response and $40 million for the COVID vaccine program to year end. The province so far has confirmed the one-time funding of $22.2 million for the ongoing COVID response, including $13.8 million for the vaccine campaign. And we've been able to provide the province with the updated projections given the changed budget assumptions, and our ministry finance leads understand how that budget was formed under a different context. So we are, given the ministry's commitment, anticipating that the provincial funding in 2022 will fully offset all the pandemic-related costs and balance our budget. So one last person you'll hear from tonight, Dr. Arif Katra of Stratology. I hadn't mentioned, but I wanted to thank him for his work as he conducted the audit of Ottawa Public Health's diversity, equity, and inclusion practices. And this is a subject Joanne Henderson-White will also present on. But just personally want to say how supportive I am of this work and committed to making the structural and systemic changes needed to improve diversity, equity, and inclusion at Ottawa Public Health. Je tiens fermement à ce travail et je m'engage à apporter les changements structurels et systématiques nécessaires pour améliorer la diversité, l'équité et l'inclusion à Santé publique Ottawa. I do appreciate the need to create strong mechanisms for accountability for advancing this work, and I look forward to regular reporting to the board and to the community on the actions being taken. So that concludes my verbal report, and I'd be happy to take any questions. Merci.
Thank you, Dr. Etches. Before we get to the questions, I'm just looking at the agenda, and I think it's very likely we're going to go past 7 o'clock, as we still have at least one more presentation and a number of delegations. So I'm going to ask Member Banham if you want to introduce the motion to extend time, and then we'll go to questions to Dr. Etches, and she can catch her breath and have a glass of water before we get to that point.
Wonderful. Be it resolved that the Board of Health approve that the meeting time be extended past 7 p.m. pursuant to subsection 8(1)(c) of the procedural bylaw.
Carried?
Carried.
Okay, thank you. And now, as I say, we'll go through the list to see if anybody has any questions for Dr. Etches. So starting with Member Tilley.
Sure. First of all, congratulations to Ottawa Public Health. I read through Dr. Gully's report, and you know, there's highlights of the communications plan. I like that it was highlighted that a lot of this response was already in place even before the pandemic hit, that we had a plan in place and it was implemented, but also in particular, the great leadership was highlighted, Dr. Etches. So to you and the team there, congratulations. Just one comment or question then is I imagine we have this great communications team ready to put in place highlighting the importance of getting the booster, because I'm worried about the apathy that's going to be out there. We talked about learning to live with COVID, and everywhere around me and people I speak to, we're all learning to live with COVID and moving forward as that. So I think it'll be, you know, I see the US president announcing that the pandemic is over. So I think it's going to be important for us to make sure we can communicate the importance of getting that booster shot. So people will indeed strive to do so. I mean, things haven't changed much here at the mission. We're still implementing a lot of the protocols, of course, but I see elsewhere when I'm out in the community, people are pretty much moving forward as life as it was, and the pandemic's over, and it might be important to remind them it's not, and get that message out of the importance of the booster. But I'm sure our team will have a plan in place to get that message out.
Thank you. Yeah, and maybe I can just say it really short, like in a very concise way. There is no question that there's value in increasing your protection against COVID this fall with a booster. So different people will be eligible for that booster at different times based on when their last booster was, or their last dose, or if they were infected recently. So we need to continue to promote the bivalent vaccine through the fall, remind people as they become eligible. But people are missing out on protection if they aren't getting a fall booster.
Thank you.
Yeah, good message to share. Thank you, Dr. Etches. Member Pinnell, you're next if you have any questions.
Thanks for your presentation, Dr. Etches. Just a little question. For those in the community or anywhere who have been afflicted with COVID, to get the booster, the fifth one, should they, I've read different things, some say to wait 6 months, others 3 months. What would your advice be?
We follow the National Advisory Committee on Immunization recommendation of 6 months because that's what is expected to give the longest lasting protection. And we recognize individuals are in different situations. Like if the COVID rate goes up, and we still actually have high levels of COVID right now. So if people are more concerned, they're at greater risk of severe illness, people may access it earlier at 3 months. So it's a possibility. And so that's really the window, and I think the other thing I was going to say, just to be really make it easier, we don't have to count the boosters anymore. So we're just saying clearly it's a fall booster, and whatever dose you had last time, now you need a fall booster at 6 months.
Right.
For some, maybe it'll be 3 months they choose after your last dose.
Thank you.
Thanks. I may have misunderstood the question, but I thought as part of that question was, what should be the interval if you've had COVID before?
Oh, sorry, I didn't clarify. So
Exactly.
yes, c'est le même. C'est 6 mois.
Oui, 6 mois.
Oui, ou on peut utiliser les 3 mois. So,
très bien.
if the recommendation is 6 months after infection, or you can also use 3 months if that's your choice.
Merci, thank you. And thanks, Chair.
No problem. Member Renard's not with us tonight. Member Lakin.
Thanks, Chair. Thanks, Dr. Etches. Just a fiscal question, may not be the right place. Is OPH impacted at all by the province's change in funding COVID-related expenses for acute care in the same way they're impacted? May start over. Is OPH impacted in the same way acute care hospitals are by the ministry or the province's cut back on paying for COVID-related expenses?
We have completely different funding mechanism from hospitals, and so the agreements are very different. And I'm probably not the best person to speak to the hospital agreements, but my understanding is there actually have been some adjustments to enable hospitals to still have the ability to have their vaccination efforts funded. So I think that was a question for a little bit. Now I'm getting beyond my territory, but so I know for vaccination that we count on hospitals for immunizing their staff and their clients in hospital, and my understanding that is able to continue and be funded. So that's helpful for the public health effort. For our work, what we're relying on is the submission to the province in the Office of the Chief Medical Officer of Health that we make to demonstrate our actual spending. And then the province, as they did in 2020 and 2021, reconciles, and has provided the revenue required to offset those expenses using our quarterly reports and our forecasting. So looking at our spending to the end of 2022, we probably would get that reconciled in 2023.
Great, thanks. I was mostly concerned that we wouldn't get the offset the way acute care has, will no longer get it. But thank you, that's very helpful. That's all I have, Chair.
Thank you. Member Kavanaugh, please.
Thank you very much, Dr. Etches, for your report. I guess this is going to be the last one for a little bit, but I appreciate it, and I'm particularly concerned about the other vaccinations for children and the catch-up that's needed. And I'm wondering about vulnerable communities and what kind of outreach is going on. Usually Ottawa Public Health is excellent at reaching out to vulnerable communities, and I wonder what efforts are being made.
Thank you. Thank you. I don't think I was clear enough because it is already a long verbal update, but I could have gone into more detail that in many ways we are trying to focus on populations where we could predict the childhood immunization coverage is lower. So we can do that in schools, and our school health team is looking at this in terms of historic levels of immunization in schools based on past reporting. And so starting with schools where we could see that there might be a gap. We're also continuing our neighborhood hubs and looking at how we can promote catch-up and immunization in those neighborhood hubs where people experience more barriers. We're looking to work with Kids Come First in CHIO to think about, as has happened previously, where there was something emerging where people couldn't access childhood immunization. Do we do something collectively for people who don't have a family doctor, for instance? And so these are all kind of discussions we're having right now to do a little bit more where there might be more challenge in accessing childhood vaccines.
Thank
But
you.
I would invite Marie-Claude Bouset to see if you wanted to add anything also.
Thank you. No, you covered it, Dr. Etches. Maybe just one more point is offering some catch-up clinics for specifically for children who do not have OHIP coverage. So that would include some newcomers to Canada who wouldn't have that OHIP coverage and wouldn't be able to access it anywhere else.
Thank you. Appreciate it, especially with the lack of family doctors. I think that's really valuable. Thank you very much.
Thank you. And we will have another update from Dr. Etches. We have one more meeting before the end of term, actually, Member Kavanaugh. So I don't know if it'll be quite as long, but but we will have another one. Member Gower. Okay, we'll come back to Member Gower. Vice Chair, do you have any questions?
No, thank you. So one comment, I guess, when I looked at the agenda for today and all of the reports, I just, it's clearly been a very busy summer for Ottawa Public Health. And what struck me is it's really a mix of, OPH inviting people to reflect and, assess what's gone on. So that spirit of continuous learning, as well as moving forward with some of the key priorities. So I really appreciated that balance and transparency. We all have areas that we can improve for sure, but I just thought that was really evident in all of the reports coming out of OPH for tonight's meeting. So lots of pediatric topical items for sure. So lots to work on, but really appreciated that balance. So thank you. No questions from me.
Thank you. Member Cloutier, please.
Thank you, Chair. Dr. Etches, thank you for the verbal report. I have no questions.
Thank you. And Member Banham.
No questions from me. Great work. Everything seems to be going really well. And it's great to see some of the other pieces starting to pick up where they left off pre-pandemic, which is great to see. So thanks for your hard work, and thank you to everybody who's listening on the call for your hard work.
Okay. One thing I should have mentioned before we vote to receive, board members will also have received a written submission from Mr. Greg McDougall, circulated by the Board of Health Secretary earlier this afternoon. It will be referenced in the minutes and held on file with the Board of Health Secretary. Can we vote to receive the verbal report?
Received.
Okay, thank you. Next up, item we held was item 8.4, Health Equity, Diversity, and Inclusion at Ottawa Public Health. I believe we have a joint presentation between staff with Joanne Henderson-White, who's been very busy since she joined us, and Dr. Arif Katra. I don't know who's leading, but I'll turn over the mic to both of you, and we'll have a listen in.
All right. Well, I'll kick it off. Happy to be here. My goal today is to present to you the key findings and recommendations from Ottawa Public Health's Diversity, Equity, and Inclusion Audit. This involved a review of the anti-racism and anti-oppression policy at OPH, which then led to a review of an additional 19 documents, some from the city, some from OPH, to provide some context around the anti-oppression, anti-racism policy. In addition to the review of the documents, it was essential to make sure that the recommendations be implementable and be practical. And so to achieve that, I conducted 25 interviews with leaders, managers, and staff across OPH, as well as some of OPH's partners and a few members of the Board of Health. A number of the staff that I spoke with were members of equity deserving groups. So with that, I'm going to share with you some of the findings. Next slide. As you listen to today's presentation, your perspective as a member of the Board of Health is very important because you have the power and position to drive change. But I'd like you to keep an additional perspective in mind. Let's call that Janine's perspective. Janine has worked at OPH for over a decade. She's from an equity-deserving group. She speaks English, but she speaks English with a bit of an accent. Janine has had the same supervisor for 5 or 6 years. And every few months, her supervisor asks her the same question. And it goes something like this. Janine, you came to Canada as a refugee, right? And Janine's answer is always the same. No, I came over as an immigrant. 2-3 months go by, same question, same answer. 3 more months, same question, same answer. A little while ago, Janine's supervisor suggested to her that she take ESL classes. It's important to note that Janine has a master's degree from Canada at an English-speaking university. I asked Janine, how did this make you feel? And she said, it solidified for me that OPH is a place where I'll have a job, but not necessarily a career. So I pushed and I asked, was that a function of her supervisor? And she said to me, you know, if one person who exhibits racist tendencies or who's discriminatory, that's manageable. For me, I think the obstacles to my career progression may actually be more systemic. So as you listen to today's presentation, keep your perspective as a member of the Board of Health front and center, but take some time to listen to what I'm saying from Janine's perspective as well. Next slide. For an organization to change its DEI context, it requires a leadership team with a high degree of wisdom and a high degree of actionable empathy. Wisdom is futuristic, it's humble, it acknowledges that what you don't know may hurt you, and it tries to fill in those gaps in knowledge. Actionable empathy, in this case, comes from lived experience as a member of an equity-deserving group. It's key to changing DEI. Wanting an audit of the anti-racism and anti-oppression policy at OPH indicates to me that the leadership team at OPH has a high degree of wisdom. And in my interviews, it was clear through conversations that members wanted to know what were their gaps in understanding. Where was the policy not meeting the needs of who works at OPH? Because they wanted to turn the dial on DEI at OPH. Actionable empathy, which comes from DEI lived experience as a member of an equity-deserving group, well, that's limited. It's limited on the senior leadership team. It's limited on the Board of Health. But despite this, when the pandemic hits, we see the front lines at OPH grow in terms of diverse staff. And the reason is because it was essential to achieve health equity. But that change was slower in leadership, and very few processes and structures changed permanently. So what does that mean? Next slide. When an organization's leadership team has a low degree of wisdom and a low degree of lived experience, that team tends to be skeptical. They wonder whether diversity, equity, and inclusion is a real problem in their organization, and they revert to collecting data. When a leadership team has a low degree of wisdom, but a number of people on that team with lived DEI experience, they often tend to jump to quick solutions to DEI challenges. Neither of these apply to OPH. Instead, OPH finds itself in an area of thinking and reflection. OPH has a complement of very wise leaders, but lacks a critical mass of leaders who have lived DEI experience as members of equity-deserving groups. The result is a lot of thinking on the part of OPH when it comes to DEI, but a reticence to act. And we see that from the limited number of changes to leadership, processes, and structures. But one thing that I can confirm in my conversations with members of the senior leadership team is that OPH is at a tipping point, and it's about to make some significant changes to the DEI context at the organization. Next slide, please. In my 25 interviews with leaders and staff across the organization and partners, it was clear to me that there is a key tension when it comes to DEI at OPH. On the one hand, members of the senior leadership team are very candid. The more the diversity, the better it is for OPH in terms of serving the community and in terms of achieving their goals around health equity. when you talk to managers who are responsible for HR functions such as promoting people and hiring people, what you hear from a lot of those managers is that we don't necessarily see formal DEI complaints increasing at OPH. In fact, our numbers tell us that, sure, we might be lagging in terms of representation, but lack of complaints indicates to some managers that maybe things are getting better. When you speak to staff from equity deserving groups, and I mean each and every staff member I spoke to from an equity deserving group shared with me multiple occurrences of incidental and systemic racism. So these three perspectives don't elegantly intersect. So that creates a tension. So what's the first step in dealing with this tension? Next slide, please. Changing mindsets is very important. From my interviews and conversations at OPH, I've learned that there is a belief at OPH that if we help people become aware of their biases and we give them capacity to deal with DEI issues, mainly through online training, that we will see representation emerge. And once representation emerges, we can then revisit the idea of whether we need to tweak those processes and structures. There's no polite way of saying this except to say that that's the wrong mindset. The reason is because DEI challenges are not simply a function or a factor of individual bias and capacity. And even if they were, changing something like an individual bias is very difficult to do. So we have to think about DEI, changing the DEI context in a different way. We have to lift our focus from the individual level to changing the organization. And the mindset to drive change at OPH has to be one that starts with changing processes and structures. When you change processes, when you change structures, and when you begin to change systems, those processes, structures, and systems drive representation. The more the representation you have in your organizational context, the larger the capacity you will have to deal with DEI, and the more checks you'll have when it comes to bias. So where do we start? Next slide, please. My main recommendation to OPH was to establish a planning and implementation team reporting up to a new member of the senior leadership team whose key responsibility it is to drive DEI at OPH. This would entail some reorganization at OPH, where teams who are key to DEI, teams like community engagement, might be placed under the new senior leader. And the team would be responsible for socio-demographic data collection within the organization to measure representation, but they would also be responsible for data collection in the community to measure user experience and user satisfaction to determine the level of inclusion that community members are feeling when it comes to OPH's, raison d'etre. This team would also be responsible for designing and implementing a number of internal and external DEI initiatives, as well as reviewing current systems that influence DEI, things like hiring and promotion. Their work would be informed and validated by a DEI advisory council made up of leaders at OPH, as well as from the community, and a focus group, recurrent focus group of elders from different communities within Ottawa. So what would this look like in terms of the rubber hitting the road? Next slide, please. Internally, it means better forms of training, case-based training, but actually where OPH has actually many cases written about actual challenges around DEI in the organization, and then using those changes to create experiential and much more effective learning outcomes. Formal mentorship with a DEI focus, identifying challenges around DEI in the organization, and then developing roadmaps for change. And then an internal DEI status report by level, by team, and by job category that would not only measure representation, which I call diversity, but it would measure inclusion and equity. From an external perspective, it means engaging in community engagement initiatives, things like an annual DEI innovation challenge, and it would be creating annual and community by community health status reports, as well as an annual DEI at OPH status report. Next slide, please. Changing DEI at OPH requires bold moves, courage to change structures, leadership, and systems. And that means changing some of the foundational elements of OPH's organization. Thank you.
Thank you. Are we going to hear from staff as well, Joanne? Or yes?
Yeah, I'm going to present the action plan.
Okay, perfect.
Good evening, everyone. Je m'appelle Joanne Henderson-White, gestionnaire de programme équité, diversité et inclusion. I will present the Health Equity, Diversity and Inclusion Action Plan for this upcoming year. Since our service area is coming together and establishing itself, the actions within this plan are internally focused for the time being. An externally focused community-based action plan will be presented to the board in the upcoming months. The timelines for this action plan is 1 year, from Q4 2022 until Q4 2023. The recommendations of focus at this time are recommendation 1, 4, 5, 6, and 8. Next slide, please. It is important, though, for us to understand what meaningful inclusion and equity is. Inclusion is not bringing people into what already exists. C'est la création d'une nouvelle espace, une meilleure espace pour tout le monde. And this is a quote from Dr. George Sefer Day of the University of Toronto. Next slide, please. So recommendation number 1 indicates that we should hire a new racialized SLT member to lead a diversity, equity, and inclusion planning and implementation team who will be responsible for driving DEI at OPH. And we're well on the way to that recommendation, as here I am with you today. So the service area manager has been hired, and as I indicated, I'm speaking to you today. Given the recommendation, the service area structure is also being developed, and gaps in staff positions are being identified to enable the area to implement the recommendations and drive DEI across the organization. In the interim, the community engagement team, anti-racism and Reconcili-Action teams have developed a collaborative working relationship to move health equity, diversity, and inclusion related work forward while we undertake steps within OPH policy and procedure to achieve the required resourcing and structure for the HID team. Recommendation number 4. Institute processes and structures dedicated to dismantling systemic and incidental barriers faced by members of equity, diverse, deserving groups at OPH. Collect DEI testimonies related to recruitment, advancement, mentorship, and retention from equity deserving employees, considering race, gender, sexuality, ability, disability, faith, religion, and language. In addition to quantitative data, qualitative data, or the lived and heartfelt stories show the true impacts of racism and discrimination of any kind as they breathe life into the experience of these employees. These stories will also be shared across the organization to raise awareness of DEI realities faced by equity-deserving employees. This work cannot be done in isolation. So we support the review of the city's hiring policies and the workplace violence and harassment policy, and with the intention to collaborate in strengthening both of these policies. HID work requires transformation at the foundational and leadership level, as we know. So we will set targets that identify equity-deserving employees for leadership roles to take part in OPH leadership programs and track their progress. Co-creation and collaboration means that we reestablish an anti-racism and anti-oppression steering committee. Accountability pathways mean that we develop a process to review all OPH policies with health equity, diversity, and inclusion lenses. Recommendation number 5 indicates that we establish an internal OPH DEI dashboard. And so we will use that to explore, we're exploring the development of an OPH DEI dashboard that will list diversity within the organization, within the various service areas, job status, and at the leadership level. Data supports accountability. So an internal data collection process that focuses not only on measuring the change levels of diversity across the organization, but also at the level of managerial ranks, job status, and service delivery teams. This dashboard will expand over time to include additional indicators that will measure equity and inclusion as recommended by the report. Is it also important to ensure that those responsible for interpreting the data and designing action plans come from backgrounds reflected in the data and apply an anti-racism and anti-oppression lens. Recommendation number 6, a transparent and easy to access process for members of equity diversity groups to report DEI challenges for formal review and investigation, and informal information sharing is also important. Health equity and diversity is exploring best practices and will consult with other organizations provincially and nationally that are nationwide that have already developed such a process. Currently, employees can report directly to their supervisors, manager, or directly to the city's workplace safety and compliance manager. Employees and leaders can consult with the anti-racism team or the city's diversity and inclusion specialist if they have any questions or would like additional support. The reporting process is shared during the anti-racism education sessions, and the information is also included in the anti-racism and anti-oppression website. Recommendation number 8, develop custom training for leaders to build advanced skills and proficiencies to deal with DEI-related challenges in a better or improved fashion. The anti-racism team has successfully developed and facilitated 2 sets of anti-racism training programs. One that focuses on the key concepts in anti-racism education, and one that focuses on anti-indigenous racism. The stories collected will be the basis for case studies that will be used to develop specialized training for staff and leaders. The work does not stop here. Oppression and anti-racism is far-reaching. It impacts on those who face barriers because of a disability related to physical or mental health, the language that they speak, their sexual orientation, religion, gender, and socioeconomic status, and the list goes on. So our focus is truly humanness. Next slide, please. Whereas the Board of Health declared racism as one of the important determinants of health, What we have undertaken thus far is a positive beginning. Change will be driven by joint implementation plans and action-focused initiatives. With the understanding that change is challenging and, yes, overwhelming, we must, in the words of Dr. Martin Luther King Jr., take the first step in faith. You don't have to see the full staircase. Just take the first step. The whole picture may not be visible at this moment, but we will see it clearly when we all, regardless of our uniqueness and difference, have a seat at the table or a part of the circle, and our voices are equally heard. Miigwech, Nakrumik, thank you, merci for your attention and your time.
Thank you very much. We probably will have questions for both of you, but we have a couple of individuals who are going to be making delegations to the board first. So Andrea Gardner, Andrea, are you there?
Just moving her into the meeting now, Chair.
Perfect.
And same with Nani.
Excellent.
There they are.
Good evening, Andrea. If you would like to make your presentation.
Yeah, here I am. Sorry.
No problem at all. Turn the mic over to you.
Thank you very much, and good evening, everybody, and thank you for having us here. We're pleased to be a part of the Board of Health's agenda today, and we'll be speaking to agenda item 8.4, Health Equity, Diversity, and Inclusion at Ottawa Public Health. My name is Andrea Gardner. I am the Associate Executive Director of Jewish Family Services, and I am here today as the co-chair of the OLIP Health and Wellbeing Sector Table with my partner in this task, Nani Cloutier. We are navigating important times of change for the better, as many of us are striving to do better after we witnessed the deep inequities facing too many Ottawa residents, particularly immigrants and racialized populations. We worked hard, enabled frequent connections and just-in-time knowledge mobilization between organizations across sectors. And we introduced new and innovative approaches to mitigate some of the severe impacts of the pandemic. Our efforts did alleviate some of the immediate risks and needs, and no doubt helped to save many lives. But we have not done nearly enough to eradicate the structural, systemic, and institutionalized exclusions that generated poor health, higher morbidity, and painful struggles of mental illness among families and individuals in immigrant and racialized communities. Now is the time to diligently analyze the sources of inequities, both in our organizations and in the systems and policies that shape our organizations, and to design new ways of working that will remove barriers, ensure that the default result of our work is equitable, and address past injustices.
Thank you, Andrea. Good evening, all. My name is Nani Cloutier, and I am co-chair of the OLIP Health and Wellbeing Sector Table with Andrea and the Executive Director of Somerset West Community Health Center. We are very pleased to read the OPH's Equity, Diversity, and Inclusion Audit Report. And the recommendations we felt emerging were robust, and the review and analysis outstanding by Stratology, and all very important and feasible to implement. And the audit brought to light normalized inequities, as Dr. Kitchery reported, that need to be addressed by the organization to serve the Ottawa public equitably. And tonight we are here to offer two recommendations and to convey to the Board of Health OLIP's commitment to support OPH's success. And firstly, we strongly urge the Board of Health to approve the Health Equity, Diversity and Inclusion Action Plan for 2022 and 2023, as described in the two reports tabled by Dr. Etches and her staff. And secondly, we recommend that the Board of Health create the necessary conditions for successful implementation of the equity audit recommendations by providing the necessary leadership, financial support, and time to allow the process to have measurable impacts. So well articulated just before we spoke. And at our end, at OLIP, we commit to ongoing support and value-add contributions to facilitate OPH's success in its journey of becoming a truly equitable and inclusive organization. And this OLIP commitment of support was there throughout OPH's pandemic response, OPH's equity audit process, including the hiring of a consulting firm, which did so well, and it'll continue in the implementation of the audit recommendations. And this because OPH is a key OLIP partner and member of the OLIP-created Equity Ottawa Partnership, a community of practice involving 26 organizations working to hone equity through peer support, knowledge mobilization, and validation and promotion of good practices. And OPH's implementation of the audit recommendations will benefit certainly from the input and support of this network of peers. So thank you very much for your attention.
Thank you both for coming out tonight. I'm only one vote, but I certainly have no issue with either of the recommendations you put forward. I think they're both quite reasonable and constructive. Are there any questions for the delegation or delegations, I guess? Okay, seeing none, thank you very much. And we'll now move to questions for our co-presenters of the strategy and the response. So we'll run through the board members for that, starting with member Banham.
I don't have any specific questions. I think you did a really great job at putting everything together. I know a lot of work goes into that, especially a lot of data collection. So just, I commend it. I'll be supporting it. But also just wanted to maybe ask a very quick question about whether Janine was involved or saw kind of the finalized versions of what is being recommended, and did that change her mind about her future at OPH?
Thank you. I can't speak to whether Janine actually saw the recommendations, but I can speak to, I conducted some of these discussions myself. And one of the things that I think is important to note is that people were hopeful that things were going to change at OPH, right? So people weren't holding the organization hostage to its past. Some were a little, but by and large, people were very hopeful that things are changing. And the overriding comment that I heard, and this is just the honest truth, was I think the way Dr. Etches talks about diversity, equity, inclusion, and her commitment feels very authentic to most of the staff that I spoke with. I mean, to all of them, not just most of them, to each and every one of them, actually. And I think that takes someone like Janine, who did say to me that, I know that's the past. I'm hopeful for the future.
Thank you. Well, I really liked many of the points, but I really like the point about mentorship and mentorship into leadership positions, because they don't just happen by wishing it to happen. They happen when people put time, effort, and funds, as you have said, into those efforts. And so I really like that piece. So thank you so much for all your work.
Maybe I can just add, Chair, if that's okay, in terms of so every person at Ottawa Public Health has had the opportunity to see the full report, as well as an opportunity to discuss it on their team with their supervisor. And certainly Joanne can speak more to this process, which her team led to prepare supervisors to have the conversation. So we went through some preparatory work and recorded presentations so they could hear directly from the anti-racism team presenting the findings and the recommendations, and facilitated guides for conversation. Probably that's not a comfortable place for everyone to discuss the findings, but we wanted everyone to recognize that there would be implications for their team and to start to think about what that means for them. So the team under Joanne also hosted debriefing sessions, discussions with some of the equity deserving groups who had informed the report. So I do think some people who you spoke to, Dr. Castro, will probably participate. And I'm very thankful people feel hopeful. That's really important for change. And also, it's not enough, right? Like, so I guess what I would say, probably what will change Janine's mind is change. So that's what we're going to wait to see if people will change their mind as we can make progress. Like, I think that's really understandably not a judgment that could be made at this time as we're taking the initial steps, I think. But sorry, Joanne, you might wanted to say more.
No, the only thing I'd add is that there was also a town hall. So there was an opportunity for people as a joint group to hear the findings and as well as to comment and ask questions.
Thank you. Member Cloutier.
Thank you, Chair, and thank you to Joanne and Arif. I have no questions.
Thank you. Vice Chair.
Yeah, agree. So thank you to Dr. Katra. I thought it was a really great report, and Joanne for jumping in with 2 feet. And again, I just really commend OPH with the transparency and the sensitivity to grapple with these hard issues. So a commitment to change isn't enough. We have to actually change. But you know, I feel like what is in the report, your presentation of the actual action plan, Joanne, makes me feel hopeful. And you know, the added piece about how you rolled that out to staff that you just covered now, I think really does get the organization off on the right foot. This is a priority. So I really commend. So no questions. Really just hope that we're on the right path, and keen to see the deliverables coming out in the next year.
Thank you, Member Gower.
Thanks, Chair. Thank you for the presentations. There's a lot to think about there. I wanted to ask what the role of the incoming board in a few months should be in supporting these efforts. What can the board do to help here?
I would say, coming from, based on what we've discussed, that continued commitment and leadership, as Dr. Etches has established, leadership, authenticity, heartfelt, an expression of collaboration, and especially a continued openness from the senior leadership team, and in orienting the board to sort of make a really good transition to let them know that what has been established and started, and to get commitment from them as well. Given that OPH is now recognized as being, on the leading edge of service and quality of service, this work to recognize equity deserving staff and to continue to support equality and access for everyone so that they're part of that circle is the message that I would be happy to see communicated to the incoming board, and some mentorship from those who are remaining and joining the incoming board members would go a very long way to support the work that we have started. Thank you.
Okay, yeah, thank you for that. I think it should be something an update to new board members and the orientation about the work done so far and what's planned in the coming years. I also wanted to ask, Joanne, I think it was in your presentation that you mentioned dashboards, and I'm curious if you can give us an example or two of what kind of indicators might be on that dashboard, because I assume it's something the board would be receiving and getting updates on, but I'm struggling to think of what some examples would be of meaningful indicators showing progress and improvement. Thank you.
So thank you for the question. I had indicated that there would be targets set to identify equity deserving employees for leadership roles, for example. So we would be able to say, okay, we've set this number of targets. This is where we've arrived in terms of progress on that specific area. And we also talked about looking at mentorship and leadership areas as well. So that those are some deliverable objectives. We talked about stories, utilizing the stories that we hear and building case studies, looking at training, how many people have participated in training, how many trainings are organized, and the uptake and the results of those things. So those would be some of the areas that we would include in a dashboard. It's some of the data that's related to health, equity, and diversity and inclusion becoming normalized and socialized within the workspace. So, and as well as support for initiatives going forward. Those would fit into a true reflection of the work within the organization. And I don't know if Dr. Etches, you wanted to add anything there that you'd like to see, or anyone else?
I'd certainly be interested in Dr. Katra's ideas on good practices too. I think what you also mentioned, Joanne, is you said it's a start, and where we're aiming, like it's the new way of working that's inclusive, right? So we actually want to measure inclusivity. That's where we want to get, that all voices are heard and valued. And so that some of that, we don't have the tools to collect that yet. We have to figure out new tools. So I think that's part of the work of the team will be, and what Joanne described is those are things we're working on this first year, and you know, I think more to come.
You know, the dashboard is actually, the intent of the dashboard recommendation is to bring diversity, equity, and inclusion data to the forefront of decision making. You know, it's quite easy for any board in any organization or any leadership team to say, oh, we support diversity, equity, inclusion. You're not going to have someone who says, no, I absolutely do not support the principles of diversity, equity, and inclusion. It's a rare perspective today. But just supporting that perspective is not enough, right? It's about action. And what the dashboard does is it puts key data in front of decision makers related to equity, for example. You know, how many people from diverse groups are in temporary positions versus permanent positions? How long does it take for you know, diverse people from equity deserving groups to progress within an organization from the time they were hired to the time they get into a more senior position? What's that timeline? Is that decreasing or increasing? When a manager and a senior leader has that information more readily available, and like Dr. Etches says, this takes time, right? Once you have these mechanisms for data collection in place, then this dashboard is much more powerful. But once you have that, then it can actually influence your decision making. Right? Because the problem with diversity, equity, and inclusion in organizations is not that people don't support it from a values perspective. The problem is it only gets supported from a values perspective and doesn't actually translate into action. And I think that is why the dashboard, the intent is to be an actionable kind of mechanism to promote change.
Okay, thank you. Merci. Thanks, Mr. Chair.
Thank you. Member Kavanaugh.
Well, thank you very much. I just want to say thank you to our community partners for coming out tonight and supporting this as well. I really appreciate it. I think that says a lot. I think that gives us a real boost that we're going in the right direction, and appreciate all the work that's done. This is absolutely the right thing to do. Follows very closely what the city is doing in terms of a anti-racism secretariat, and I appreciate all this work, and I'm very proud that we're doing this. Thank you.
Thank you. Member Pinnell, please.
I have no question. I just wanted to thank you for all the work done. Merci pour la présentation. And also thank you for the community partners that came this evening. Thanks.
Member Lakin.
Thanks, Chair. Thanks to the group for the presentation. Fantastic work and certainly fully support it. Councillor Member Gower asked a good question about what the board can do, and I think in supporting the policy, I want to support the notion that the policy would be applicable not just to staff, but actually to the board itself, that in recruiting, selecting and operating as a board, the same EDI framework and lens could be a valuable extension. It's something that every board is trying to do, is to enhance its EDI commitment. But I think as we're at OPH embarking on it, I'd encourage the policy to extend to how board members are selected. Thank you.
Thank you, Member Lakin. And last but not least, Member Tilley.
Oh, great effort. Congratulations again to everyone involved. Thank you, Dr. Chatra and Joanne, for your presentations. And it's great to see once again Ottawa Public Health at the forefront, moving ahead with courage and transparency to tackle these tough issues, and absolute transparency in the way this was handled. So thank you.
Thank you. Just a couple of really quick comments, if I may. First of all, I had quite a lengthy conversation with Arif, and I got a good sense after that conversation that we were going to get a very constructive, transparent evaluation of where we were and what we could do. So I'm happy to see that that's actually what happened. That was certainly my sense after our interaction. So I want to thank you for the work that you did to help us get to this point. And Joanne, just, you've jumped right into the pool. You got hired, and we just said, here's a little project we'd like you to work on, and without hesitation, you jumped right in there. And I have to say that I love the quote about the staircase. We have one more board meeting to count Member Gower's question. There's going to be a brand new board in a few months that you'll be working with. But I don't think anybody in this call, in this meeting, should miss the point that somebody has to be there for those first few steps, be prepared to take those steps. And so I would urge all of my colleagues, I think we're there. I don't think I have to urge you, but if I do need to urge you to join Joanne in taking those steps and moving the recommendations of this report and the recommendations of the action plan forward. Again, we may not all be here at the top of the staircase when all is done, but again, somebody needs to take those first few steps, encourage those first few steps. And so I would urge all of us around the board to firstly receive the results of the diversity audit as found in document 2, and secondly, to approve the health, equity, diversity, and inclusion action plan for 2022 and 2023 as described in this report. So can we receive and approve then?
Yep.
Thank you very much. And thank you again to the delegations as well for coming out tonight.
Thank you very much. And I would like to take a 20-second clip to just say thank you to Naika and Zainab, who were really instrumental in doing a lot of the work with Dr. Katra prior to my presence. So heartfelt thank you to everyone. for the teams and excellent work and excellent foundation. Without them, we couldn't move to this point. So thank you.
Thank you.
Thank you. The next item that was held, I held it actually. We don't have a presentation on, but we do have Dr. Gully here. And if anybody has any questions, as I indicated, I have a couple of questions, but I'm happy to yield the floor to any board members that might have questions first. Okay, I don't see any hands. So I guess the question I really had, it's a wraparound kind of question, I guess, Dr. Gully. First of all, thank you for the work you've done for us. But I'm wondering if you could just very briefly, because I know it's late, you've been with us waiting for a long time here, so I don't want to keep you any longer than necessary. If you could tell us what you believe the biggest challenge was for the organization during the COVID response, and what you think, because you're quite clear that this sort of thing is going to happen again, quite potentially. What you think our biggest challenges going forward, and more importantly, not so much for this board, but again, to echo what Member Gower said, but for the board coming in, what do you think we need? Do you think we're equipped for the next whatever it is that comes along? Or are there things that the next board should start talking about right away to get ready for that next virus, next whatever it happens to be, so that this board can bridge that between your report and what the next board should be concentrating on as they begin their term?
Thank you, Chair. I think the biggest challenge at the beginning was to recognize that this what was happening in terms of this pandemic was different from what any of us had experienced before. I think everybody worldwide was in that position too. And to be able to sort of think forward, and now, where we are now, even begin to recognize the huge social, economic, and other effects of this pandemic. So I think that was the challenge at the beginning, is it not knowing what was going to happen. Having said that, what I found was that Ottawa Public Health and the staff and the partners in the community, but Ottawa Public Health, was willing to look at the information coming forward, the surveillance, local, national, international, and then make the necessary changes in terms of the traditional public health response to that. And I think, and I said in my report, that was extremely important. The prolonged nature of this, I think, is something which, as I've said in my report, is going to be really important to at least keep thinking what will happen if this happens next in terms of a long commitment to responding to an issue like this. And that particularly comes into things like issues of human resources, hiring people, maintaining that, finding the right people, promoting people, having people that are sufficiently trained who can be promoted in the short term, and then the personnel challenges of stopping burnout, recognizing that everyone, this is diversity, everyone has very different issues to deal with at home and in the workplace, but having a structure that can continually do that. And I think that always has to be in mind. I think going forward, it'll be incredibly important that you, the board, and Ottawa Public Health future board thinks about what the fundamental infrastructures are that are important to doing the job now. And I think surveillance and investigation, collecting information about what is happening, not in terms of communicable diseases, non-communicable diseases, injuries, the effects of climate change, having sufficient infrastructure in place to ensure that you know what's going on a day-to-day basis, because then that will translate into communication. I mean, Dr. Edge has talked about already in terms of the updates, in terms of COVID. You know, I wonder how many people look at those updates each week, but the very important thing is that when people suddenly realize there's a problem, they know where to go to, and they hopefully will have the confidence that Ottawa Public Health will have the information there on the website and in other forms of communication that will be able to then answer questions that they have. Questions which a lot of people are ignoring and not answering now, but they will be there once necessary. And I think that's incredibly important, because that surveillance investigation capacity will then translate into the public health policy and then communication to the public, to the communities, to decision makers such as yourself, and also then maintaining that partnership with the diverse communities that you have in Ottawa. So I mean, I'm grateful I'm not in a position of having to deal with budgets anymore. But as it go forward and there will be pressures, is that keeping in mind what is most important and where that balance will have to be in the future. And you working with Dr. Edges in terms of saying this is what's most important to maintain and build on. And finally, I might say is that the last item on diversity, equity, inclusion, that's the right thing to do. But also, I think it was shown that the partnership and recognition of the importance, both recognizing that diversity in the community, but hopefully also within Ottawa Public Health, is vitally important to the success of any operation and any programs as you move forward.
Thank you very much for that. Again, before we vote to carry the report, does anybody else have any questions or comments for Dr. Gully? Okay, well, thank you again, Dr. Gully. It's a fascinating read. It really is to see how we navigate it through, or how it was perceived that we navigated through. It's always good to have a second set of eyes to look at what we've done and how well we have or how well we haven't done that. So I want to thank for that very much.
Thank you.
So can we carry this report then? Thank you. Sorry, there's more that we need to do. That the board that the board also receive for information the findings from the third-party review as outlined in the consultant's report, attached as document 1, and 2, that we direct that Ottawa Public Health consider how best to advance each of the consultant's recommendations found in document 2 attached within existing planning and operational cycles. So can we receive and direct in that regard?
Yes.
Yes.
Thank you very much. The next item that we have that was held was our update on our public health fall 2022 immunization plan. And we have a couple of public delegations to hear from. And Deanne, do we have Dr. Brophy?
Yes, we do.
Okay, so we have Dr. Brophy and Dr. Zwicker as well. So we'll welcome both of you. We'll start with Dr. Brophy and then segue into Dr. Zwicker.
Thanks very much. Can you hear me okay? Great, thanks. I'm calling in from out of the country. So thanks for allowing me a few minutes to speak tonight. I'm an infectious disease physician at CHIO, and I'm here tonight representing our CHIO Division of Infectious Diseases, as well as the Greater Department of Pediatrics, regarding our concerns about childhood immunization in Ottawa. As you heard a little bit about already through the Kids Come First partnership, CHIO and Ottawa Public Health at the beginning of the pandemic back in 2020 did establish an immunization clinic because we knew that children were falling behind with their vaccinations in the city because of closures of physicians' offices, as well as the Ottawa Public Health vaccine clinic. And during a couple of months in 2020, between May and June, we had a 3 days a week clinic where we vaccinated almost 300 children against, well, for their primary immunizations, less than 2 years of age, as well as kids new to Canada who needed catch-up vaccinations. We did a survey as part of that clinic. These were children who weren't able to access vaccines in the community. And we asked them where would they normally be going, and about 56% of them had a primary care provider who wasn't providing vaccines at that time. And another 45% had no primary care physician in the city, which I think is very telling and concerning overall. So during that time, we had hoped that things would, quote unquote, go back to normal, which we know didn't happen. And the pandemic has dragged on, and lots of challenges have come up in the interim. Many people have retired or closed their practices in terms of primary care providers. Ottawa Public Health has been called upon time and again to deliver many additional add-on services that weren't normally there before, including rollout of many COVID vaccination campaigns, as well as now monkeypox vaccine. And so we at CHIO continued to try to provide vaccines for kids who had no other options because we knew that it was very important, and we really felt strongly about that. We also had a nurse practitioner who we had hired to open a travel clinic, pre-travel vaccination clinic, which obviously was poorly timed in terms of the pandemic because no one was able to or traveling anyway. So for one day a week over the last couple of years, we've been providing that service through referrals from Ottawa Public Health or from direct referrals within CHIO. And over the past 3 years, we've actually vaccinated over 600 children, about a third of whom are under a year of age, which is probably the most important time of vaccination. They're at the most vulnerable age for vaccine preventable serious illnesses like meningitis. But CHIO can't continue to do this. We lost our nurse practitioner. We have lots on our plate as well in our infectious disease department. And Ottawa Public Health likewise has lots on their plate in terms of being unable to keep up with the demand of the 10 or 20% of people who don't have primary care in the city. And so I really feel that it's important that with this lack of primary care providers in the city and a lack of alternative places to get vaccination, we need an urgent plan. We need a way to solve this problem because frankly, this is a disaster waiting to happen. A child is going to die of a vaccine preventable illness, and then it will turn into a different conversation of how can we solve this even more urgent situation. We don't want to get to that point. And so I would call on the Board of Health to think creatively. I know Dr. Etches mentioned already that the Kids Come First consortium of partners is trying to come together to find a solution, but we need an urgent solution. We need a long-term solution in terms of who's going to provide vaccines going forward, because we don't have enough primary care providers available for it, but we also have an urgent situation. And I think it requires something bold, like hiring a full-time nurse for the next 6 months to get kids caught up in the city, because it can't be on the back of or off the side of our desk with all the other work we have to do. It needs a dedicated program. And so I'd really call on the Board of Health to think of what you can do to help the children in our city. Thank you.
Thank you, Doctor. Are there any questions for this delegate? I don't see any hands, so thank you very much for coming out. I take that back. Member Kavanaugh has a question for you.
Yeah, thank you. Well, we were talking a little earlier about the childhood vaccinations. What about schools and approaching through schools, which is often normally done for vaccines, and through the provincial government? Is that a possibility? Obviously, public health is all very much in the lead on vaccinations, but what is the response there?
I think that's very reasonable for school-age vaccinations, but we're talking about children under 2 years of age who don't go to school yet.
Oh, okay, the young ones. Oh, sorry about that. Okay.
And really, they are the most important ones. They're not protected against measles. They're not protected against the most common causes of meningitis. And really, these are extremely important. We've seen so many children who are behind, like they're 7, 8, 10 months of age and haven't had any vaccines yet. And these are the people, the ones we're seeing at CHIO are the ones whose parents were motivated and sought out a solution. We don't know how many kids are unvaccinated and their parents aren't seeking solutions for that in the city because we don't have a good way of tracking it. We know that the requests for vaccines at family doctors' offices are way down. So we know that the delivery is down because they're not being requested. But as I said, this is really a catastrophe waiting to happen.
Yeah, no, it's concerned. I suspect this would need, if public health did it, would need a new boost of funding from the province. So I expect that that's what you're requesting us to ask for. Okay. Rather than within our current resources, which are obviously pretty much spoken for, especially during the pandemic, but would love to be of help. Okay, thank you.
Thank you. Are there any other questions for Dr. Brophy? Seeing none, thank you once again, especially it sounds like you're away on business, perhaps travel. So thank you for making the time to connect with us. And Dr. Zwicker, I'll turn the mic over to you.
Hey, can you hear me okay?
Yes, just fine.
Hi. So thank you for having me speak about the importance of routine childhood vaccines as well. And I bring the perspective of the community pediatrician. So my name is Kelly Zwicker. I'm the founder of the Ottawa Community Pediatricians Network, as well as I'm the current division head of community peds for CHIO. So I speak on behalf of some of the anecdotal concerns and knowledge that we've garnered over the past several months as community pediatricians. To echo what Dr. Brophy has just mentioned, access to getting routine vaccines in younger age groups, so those are the 2, 4, 6 months and the 12 and 18 months, like kids that are younger than 2 years, has declined. And so these vaccines protect against polio, tetanus, meningitis, and other very preventable diseases. Normally, they're delivered in Ontario through individual physicians, so the family medicine specialist or the community pediatrician. And we know that in Ottawa, the majority of routine vaccines are actually provided by family medicine specialists, and most of those practice independently. And from a pediatric standpoint, there are a handful of pediatricians who provide primary care, but the majority of us in the community provide sort of a specialist-based care. And we're noticing that parents are not up to date on the routine vaccines when we ask them. And so we've been talking at our meetings about how in our day-to-day workflow, can we bring this to the forefront of parents' minds? And we're finding that people are just simply forgetting that the routine vaccines are just as important as, say, a COVID vaccine. We're finding that access is a problem. And so a lot of family medicine specialists and other pediatricians have retired. There's nobody to replace their practice. And we don't have a model in other provinces like where you can kind of drop into a CLSC or like a public health to get these routine younger vaccines. And so we're keen to be involved with strategies from the context of the OCPN and community pediatricians. So we've started to work with Kids Come First, as I'm sure you've heard about before, to try to explore options where we can overcome some of the barriers. These are short-term solutions that we would hope reach broad populations of kids, but we know there's lots of work to be done. And we've also talked about changing one of our COVID assessment centers into a place where we can do blitzes for routine childhood vaccines. But we know that more needs to be done because we need to reach a good number of children that are young for these routine shots. We're very concerned that gaps in this immunity could lead to an eventual increase in vaccine preventable diseases. And we know that we're just a small part of the puzzle as pediatricians in this city, and we'd love to be part of a short-term solution and a long-term solution, but access is really challenging. So unfortunately, in my 10 years as a pediatrician, I have seen babies die of meningitis, unfortunately, in the northern communities where they had trouble staffing the community clinics. They got behind in the Northwest Territories, and babies would come through the hospital in Yellowknife at 10, 11, 12 months of age, and they would die of meningitis. And I'm sad to say that, and it sounds very catastrophic, but we're quite worried that this might be the possibility in Ottawa, and we don't want that to be. And so that's why I greatly appreciate the time that you've given us to talk about this important issue. Thank you.
Well, we appreciate you coming out, especially as it's been a longer meeting, so we're probably getting to you a little bit later than we normally would. Are there any questions at all or comments either for Dr. Zwicker or Dr. Etches or staff? I see the vice chair's hand up, so over to you.
Thank you, Chair. And thanks to Dr. Zucker, Dr. Brophy. You thanked us for the time, but I can think of no more busy people than the both of you. And so I have the pleasure of working on different initiatives with them both. I think I just wanted to draw the board's attention to the fact that we're trying to do catch up. And I think everybody around this table and I know at OPH are, committed to that. One of the things that we do struggle with is having a real lack of data before kids hit school. So, we're I think pretty proud in Ottawa about the robust follow-up, on school age kids with vaccines and, facilitating them getting the vaccines, all of those things. The gap that we have that everyone is really worried about is the 4 years that before. And, to your point, Kelly, around, meningitis risk, we saw the polio piece happening in to the south, and we can't wait 4 years for that to be cropping up and to realize we have a problem. And so that real coming together of the community. And so I'm really happy to hear OPH engaging with, Kids Come First, for sure, all of our community partners to really rally around this issue and put our heads together about how we fix it. And I guess my question for our OPH colleagues is, around that urgent response. And do you feel like we're getting enough traction to really be doing something in the near term so that we don't wind up having a big problem before we know it when the kids are 4 years of age?
I have many thoughts as we're looking at this. So the first thing is our team is trying to quantify the challenge so that we can plan to meet it with partners. So it is helpful. Like, I'm not sure hiring one nurse is going to do it, actually, right? Like, so we can make rough estimates based on assessing, worst case scenarios of the lack of access to existing providers and the change in the ordering. They're rough estimates. But we're committed to doing the best we can to show people what the work is that needs to be done, and then collectively plan to do it. It is bringing to mind also, I believe, and I'm maybe someone else can confirm, but I think as a Board of Health, you have been on the record to say we need to improve our immunization system in Ontario and Canada. Like, we need a vaccine registry so that we would know when all of the vaccines are given or they're not given, and we can send out the reminders that help parents know, oh, I'm just forgetting, I'm behind, it's time. Like, these are very evidence-based approaches that have been shown again and again to make a difference in keeping coverage rates up. If you just proactively tell people when they're due, we are using tools. I mean, if people have access to smartphones, there are ways they can sign up and get notices and alerts, like we're trying to promote it, but it's not the same. A vaccine registry allows us to know whether it's a pharmacy or a primary care provider or a hospital, pediatrician, or public health, what's happening with the immunization status of children and adults. So we're talking about children today. but we also have no information on our whole population of adults. So I'm certainly in support of bringing this back to the board in terms of saying how we've been able to go forward in terms of quantifying and as a collaboration, making plans to close the gap short term. I liked that distinction that was made in terms of short term, urgent, and longer term. I think that it is, you can see, it came through in our verbal and our reports. This is something we are concerned about. Marie-Claude, in terms of leading immunization and the team that's actually thinking about how we can help, did you have anything you wanted to add?
No, I think you covered it, Dr. Etches. So there's definitely a need to get more information on the immunization coverage of the whole population, but especially those very young children before they enter school. And also, as was mentioned, Ottawa Public Health is working with partners and with primary care to see if we can, increase the catch up on childhood immunization. But you've covered it, Dr. Etches. Thank you.
That's great. Thank you.
And Member Banham.
Thank you. I have a couple thoughts, and thank you both for being here and responding to the call during the last almost 3 years are we going on now. But I guess one of the short-term solutions I'm wondering is, in my day job, we run a 0 to 5 COVID clinic, or public health does, but at the birth center. If kids are already coming through and understanding they can't get them at the same time, the immunizations, but could we not be leveraging sites like that to do these other vaccines because it is the same population coming through, and being like, okay, so you're actually due for this, come back in 2 weeks and we'll give it to you then. Just wondering if that's a short-term solution. And then the next piece would be, I know Kids Come First is involved in talking about these solutions, but kind of bringing in some of the lessons we just learned with the equity approach, would it make sense to also bring some partners from OLIP into that conversation to make sure that we're going to be able to address all people with this solution? And then maybe also CMNRP, where OPH is present, but they do have a mandate to also be looking at that first year. So they might be able to collectively resource their partners to see what we could, in at least the short term, be trying to find some bodies and some commitment from our partners to work on this.
Yeah, I think this is a time where we want to see if anyone who can do a piece, can come and help. So I think Marie-Claude will probably follow up on some concrete ideas. I mentioned earlier, we are taking that neighborhood-based approach and working with populations who may have greater barriers to immunization. So that is a lens we're certainly trying to apply. And it does take money to pay staff to immunize, right? We do have to pay salaries with money that we know is coming. We can't just send people and not have money to pay them. So that is, a reality, but we're constantly looking at priorities and trying to, do all we can with the resources we have. So I think, again, many people coming to assist, could definitely make a difference. We live in a wonderful community of many people who rise to these occasions. We would just need to have more of a plan with different partners. Yeah. Dr. Zwicker.
I was just, oh, sorry. I was just going
to recognize you, Dr. Zwicker. Saw your hand up.
No, apologies. Very quickly, I just was going to say that we do live in a wonderful community, and the way that we can bring the neighborhood together to do this, I think will get done imminently in the short term. I do worry about that enabling the long-term problem, and not to be contrarian, but coming from a province that did have a vaccine registry from 0 and upwards, it was lovely and very helpful. So I would just really echo the push to establish one of those in Ontario, if at all possible.
Thank you for that. I don't see any hands up. On that point, though, Dr. Etches, is there something you'd like the board to do in terms of a registry? You want a board motion, a recommendation for a letter to be sent to the appropriate ministry? Anything we can do tonight?
Well, I was challenged to remember if we actually asked for that previously. I would be surprised if we haven't. So Marie-Claude might recall having led immunization at different points, but there's been some gaps in your responsibility for that. So probably it might have happened while you weren't here. And Deanne is a resource in terms of knowing what the board has done. But maybe we'll take that away. And as I say, I think this is urgent enough. We'll be coming back to you to let you know what's happening. And maybe at that point, if we can confirm we haven't asked for registry, we could suggest that.
Okay, perfect. Again, I don't see any other hands. So can we receive the report then?
Receive.
Okay, thank you very much. And thank you, doctors, for coming out tonight. And I believe we are at the time when we will ask, we have no in-camera items, so we can ask Member Banham to bring the motion to adopt reports.
All right. Be it resolved that the presentation by Dr. Daniel Myran, Cannabis Poisoning in Children Following Non-Medical Cannabis Legalization, the Chair of the Board of Health Verbal Report, the Medical Officer of Health Verbal Report, and the reports titled Health Equity, Diversity, and Inclusion at Ottawa Public Health, Reconcili-Action Plan Update, Annual Report, Results of the Third-Party Review by Dr. Paul Gully of Ottawa Public Health's COVID-19 Response, Recovery Planning Status Update, Update on Ottawa Public Health's 2022 Fall Immunization Plan, Ottawa Public Health's Strategic Plan for 2019 to 2022, Update from Q2 of 2022 Operating and Capital Budget, Q2 Board of Health for the City of Ottawa Health Unit Status Report, Delegation of Authority Contracts awarded for the period of January 1st to June 30th, 2022, and Performance Appraisal of Medical Officer of Health in camera, Personal Matters about an Identifiable Individual, Reporting Out Date, Not to be reported out, be received and adopted.
Carried?
Carried.
Okay, are there any motions requiring suspension of the rules? Okay, are there any notices of motion for consideration at a subsequent meeting? Okay, can I get Member Banham to please move the confirmation bylaw?
Absolutely. Be it resolved that confirmation bylaw number 2022-5, a bylaw of the Board of Health for the City of Ottawa Health Unit to confirm the proceedings of the Ottawa Board of Health at its meeting of September 19th, 2022, be read and passed.
Was that carried?
Carried.
Okay, thank you. Are there any inquiries? Okay, seeing none, we will adjourn. Our next and our last meeting is November the 7th, at same time as usual. So I look forward to, well, sort of look forward to our last meeting, but I think it's, I've got to read something here before we go, because we're not having the media availability tonight, apparently, because due to low registration, we will not be moving forward with the media availability after the meeting. Media requests related to this evening's board meeting can be directed to ophmedia@ottawa.ca. I'm kind of sad we don't have more reporters. I think we did a lot of good work tonight. A lot of heavy, important reports, a lot of good delegations. And so I want to thank everybody for sticking in through the whole meeting. It was a lengthy one, but again, I think we did some really good work tonight. And I want to thank you all for your support for the various initiatives put forward by Dr. Etches, the staff, and the various consultants. And of course, I want to thank Dr. Etches and the staff once again, and the consultants, if they're still listening in, for the work that they've done for us. I think we've set a good foundation on a number of different topics of concern for the organization going forward. And again, to go back to Member Gower and, what does the next board do? Well, I think we're giving the next board plenty to do with the various things that we passed this evening. So thank you, everyone. And I look forward to seeing you at the last meeting.
Thanks all. Good night.
Thank you.